Good afternoon, everyone. Dear friends from the American Academy of Oral Surgery, best regards from New York in a beautiful day. And I come to you online to lecture about immediate loading of dental implants in conjunction with bone grafting. And as you know, this is something which could be contradictory as a topic and very interesting for private practice and for academia. And I will focus also in my presentation on long-term results. I'd like to thank for this kind invitation, the AOS and Dr. Shah and his team. And as you can understand, with these small difficulties we have today with the technology, the biology seems to be more important than the technology, but we need the technology in order to accomplish our daily goals. As we know, the immediate loading of dental implants is a concept which is not very new. Exists in the international literature from the 70s, from Philip Lederman, who placed implants in the anterior mandible because the bone was, or it is very good in the quality in the most of the cases. The implants at that time were one-piece implants, and he was able to connect together within 3 to 4 days after surgery all of these implants with a rigid restoration, a rigid bar restoration, which was in connection with an overdenture. Later on, as we all of us know, P.I. Brånemark introduced the Brånemark Novum, where he placed 3 implants in the anterior mandible in patients with edentulous maxillae. And again, these implants, this time 3 implants and not 4 implants compared to Lederman, they were connected with a very rigid bar, and the patients had in the maxilla a full denture. Later on, others presented the concept of all-on-4 with 2 tilted implants in the maxilla or 2 tilted implants in the mandible. And we know today that we have long-term data without any grafting. The mode of the loading mode definition has been published in many, many different papers. Here you see that we can talk about immediate functional loading if we place the implants and at the day of the surgery, the temporary restoration has occlusal contacts, some occlusal contacts. If the restoration, temporary restoration, has no occlusal contacts, we talk about immediate non-functional loading or immediate temporarization, also called provisionalization. In general, the implants heal in connection with immediate loading, like in the fracture healing, where we have fragmented bones, like here in the lower jaw, and osteosynthesis plates can be placed with rigid, with good stability. And then the patients after surgery are able to chew soft liquid food, or of course, not to eat chicken bones or chicken wings, which is something harder. If we look a little bit in the literature, we will see also basic science studies, especially from Japan, in the rabbit tibia, for example, where they made holes and they started pulling within 2 weeks these tibias of the rabbits. And you see here new bone formation in the one side of the rabbit tibia in 2 weeks. And after 4 weeks as well, we had much more bone formation. And in the contralateral side, the new bone formation is not here visible. In a similar way, we can explain another experiment, the bone formation under compression, when rabbits have in the tibia similar size holes, and under compression, the bone is once or twice a day loaded, and you see after 2 weeks of compression and after 4 weeks of healing, much more bone formation. In a personal note, I would like to mention to you that I had the possibility to be for a couple of years in Malaysia doing with the team over there and with the German team studies in the posterior mandible in macaque monkeys. We placed implants in the posterior mandible with different implant designs, and after 3 months of healing, we were able to euthanize the monkeys and to see that the implants were osseointegrated with a very thin carpet-like bone, which was in close contact, in tight contact to the implant surface. If we look now the bone to implant contact percentages, you see that we had almost 40 to 45% bone to implant contacts, independent on the design and the characteristic features of the threads of these individual implants. But in another study, we were able to load implants after healing, and in the same jaw, in the same animal, we were able to compare this healing with implants of the contralateral sides where we had immediate loading forces. In other words, at the day of the surgery, I was able to place the abutment and the provisional restoration at that site, at the right here slide, and to compare histologically after 3 months of healing with the implants which have been placed 3 months before at the contralateral site, and these implants were already also integrated. You see here that the monkeys had occlusal contacts in the provisionalization. And if you see now, the percentage of the bone to implant contacts is almost 20% higher, greater than the contacts we had without loading forces in the previous study. So 60 to 65% BIC percentage in this particular study. The studies have been published in different papers and in also books. And you see here, when we have the same abutment, without to remove the abutment, we have the possibility to see bone formation in these monkeys over the platform of the implants. And the remodeling occurs. And if you look here carefully in the right slide, we do not have any migration of the long junction epithelium around the abutment. So in another specimen, you see also characteristically that where we have occlusal forces and loading forces, the bone response is higher. The pink color here represents the remodeling of the bone. And in the apical threads of the implants, you see that there is absolutely even no bone. Why? Because the posterior mandible has much more weaker, soft bone, much more softer than the anterior maxilla. Similarly to the periodontally involved teeth, the bone seems to have better remodeling around the roots where we have occlusal forces. Someone could think, why do we compare humans with monkeys? But this study by the University of Indiana shows that humans and monkeys have similar bone to implant contacts, the blue bars here, if you compare these specimens in a very close distance with the implant body. So at the bone to implant interface within a distance less than 1 millimeter, we can see similar effects between humans, monkeys, rabbits, and dogs. And this remodeling is completely different, far away from the bone to implant interface. So why we discuss about this today? We know from the daily life that astronauts of NASA, they are in the space and they lose every day due to the lack of gravity, bone. There is a need for bone formation, but these astronauts lose the bone due to the lack of gravity. And then when they come back to the Earth, they have better remodeling and new bone formation. Orthopedic surgeons do today the same thing when patients have fractures of the tibia, for example, in the legs. They cast initially the patients if they do not have good primary stability of the osteosynthesis screws. But if they have a good stability, they are able to say to the patients, please go ahead, get up from the bed and walk every day, but not to jump, of course, or to ride a bicycle. In a similar concept like in the monkey studies, we evaluated in the past humans in the University of Frankfurt at the time when I used to live in Germany. And you see here that the right side of the patient here has received 3 implants, which have been included in this particular study. The 4th one is independent. These implants have been loaded first after 3 months of healing, and they have been compared with the contralateral implants, which have been connected with the abutments, stock abutments, and these abutments have never been removed, and the implants were loaded with provisional crowns and bridges, splinted actually crowns. And after 6 weeks, we took the impressions from the abutment level, we fabricated frameworks, and after that, we cemented the final restorations. And you see here in both sides, at the left and right side, the bone levels at this specifically radiograph. And if you compare the radiological and clinical examination after 3 years, you see the soft tissues around the implants in the test and the control group. And if you look later on how this bone looks like crestally at the immediate load implants compared to the delayed loading, we didn't have any difference at all. In a comparison now of 10 patients from this study, 2 patients were dropped out because they had they left to go to the different city, and we were not able to see them. We compared after 15 years of loading, the test immediate loading group of implants with the control group. And as you see in the crest of the bone, mesially and distally, we didn't have any differences between the 2 groups, and the bone level was, or the bone loss was less than 2 millimeters. I'd like my friends here to emphasize, because it's the key of my presentation, in order to avoid to have crestal bone loss, you should not remove the abutment of the implants. And you see in this case, after many years, as you can see here, after 15 years, how the situation looks like between the immediately and delayed loaded implants. And if you compare in another patient after 12 years or after 13 years, we didn't have crestal bone loss, and more important, we didn't have any failures. This is the case where I'd like to focus on my presentation now. What happens if we have to deal with bone grafting? And this was my first patient years ago when we did in the anterior mandible in individual positions, actually prosthetically driven concept, placement of implants with good stability and placement of the abutment or abutments. And in the same day in the maxilla, I placed 6 implants as well, and I loaded immediately after surgery. So you see now how the situation looks like with the provisional restorations. The provisionals should not be always perfect. In the reality, I emphasize that the occlusal contacts have to be slight, and the patients use soft liquid diet for the first weeks of the healing and sometimes for a couple of months. The restorations have been cemented with temporary cement with Tembond. We didn't have any problems and risks of peri-implantitis in that way. And you see how these implants look like after years, and how these implants look like in over a period of time. And after many years, as you can see here, the patient has been treated by other doctors right now. Actually, I have to say, I didn't see the patient for many years because I moved to US, but someone removed the restorations, replaced the restorations in the mandible with new abutments and telescopic retained prosthesis. And I'd like to emphasize here that we had crestal bone loss after this period of time. If you compare with the maxillary implants, which had the same abutments over 15 years, but for some reason, the patient lost 1 implant, the short implant of 8 millimeters in the distal part of the maxilla. So now in another patient, we had to deal with the mandible with good primary stability of the implants, placement of the abutment straightforward, and then immediate loading. The patient was very interested to have, because in the maxilla it was a dentulus, after a couple of months to have immediate loading concept in the maxilla in order to leave the full denture. And here we had to deal with augmentation using autogenous bone. The previous speaker, Dr. Sankita Pai, mentioned about resorption of the crest of the bone, or in general, resorption of autogenous bone grafts. But here we'd like to control the bone resorption, and I'd like to show you with this presentation how we can speed up the healing of implants and what opportunities we have in order to have less problems with crestal bone loss or in general bone resorption. The immobilization of the collagen membrane occurs here with titanium tacks. And if you look carefully, after 3 years of follow-up, the patient has here the same bridges. We had the possibility to evaluate the implants after removal of the prosthesis. And even we had the distal cantilever bridges, we didn't have any problems. But the only prosthetic problem we had after 5 years was the distal cantilever in the right side was broken. And I'd like really to be honest with everybody in the AOS, because it is important to be honest and to emphasize on the complications. After years, we had to replace the bridge in the right side to separate with the remaining bridge. And you see the follow-up after 5 years. And if you compare after 15 years, the same patient with the new prosthesis, for some reason, the prosthodontist replaced the prosthesis in the maxilla and in the mandible. maybe in order to evaluate how is the cleansability if this prosthesis is telescopic retain restoration, but you see that the crest of the bone is almost the same. So now I go to more advanced cases. In this particular case, the patient lost the left maxillary canine. We had to deal here with a vertical and lateral augmentation. And here I used a corticocancellous block from the posterior ramus. As you see here in the radiograph, in the Panorex, the bone was harvested from the left ramus. And I'd like to make clear, my dear colleagues, that this bone is a corticocancellous block, which was stayed in for a remodeling of 4 to 5 months. And after this period, we place the implants in the correct prosthetically driven position, and we load these implants with a provisional restoration. The panoramic radiograph shows to you how the implants look like immediately after surgery and delivery of the prosthesis. And after here 1 year, we had the possibility to evaluate the patient with the final prosthesis. And I'd like also to show you to you after 2 years how the bone looks like, even we have 3 distal cantilevers here in the size of a premolar, but also after 10 years, how the situation looks like when the patient has received from some other clinicians 2 identical implant systems, and we had the same prosthesis in the maxilla. The bone is without any crestal bone loss because the abutments are the same. Nobody removed the abutments. So I go now much more advanced in the posterior maxilla when we have to deal with sinus lift procedures and sinus augmentation. To be honest, this was one of my first patients in my career where in the dentulus maxilla, we placed implants and in conjunction with the lateral window and sinus floor elevation. The bone which was used here was autogenous bone from the tuberosity. The implants were placed and we loaded them immediately after surgery. And the prosthesis was a provisional restoration where the patient had to use a soft liquid diet for the next 3 to 4 months. All the implants were splinted together. You see how much bone was here at the upper left side in the residual bone in the maxilla. The implants immediately after surgery, and after 3 months of healing, you can see the remodeling of the autogenous bone due to the loading forces. And this is something what really I'd like to make clear in this presentation. If you would do the same thing without to place implants and without to load this bone, you know very well the bone would collapse. That's why we like to use xenografts in order to stabilize the bone. But also the previous speaker mentioned, xenografts are actually also conductive. Autogenous bone is also inductive. So now you see when we deliver the restoration and 1 year follow-up, how the situation looks like, how the bone looks like, how the situation is stable over a period of time here after 4 years. Please observe now the situation after 18 years. And I'm really so sorry if it is not very sharp in this slide, but this is a slide which I received from Europe a couple of weeks ago. So 18 years follow-up showing no crestal bone loss, but the bone grows because we have here autogenous bone in conjunction with immediate loading. The question we have now is, what would happen if you place an implant, you have a dehiscence as you see here, and you place an abutment? Would you be able to load this implant in occlusion or out of occlusion? And the situation becomes critical when you read the literature and the people talk about torques of 30 to 35 Newton centimeter. And I'm positive most of you would never place an implant in an abutment under loading under these circumstances. But like also a little bit to explain to you, something what we published in the year 2009, years ago, where we see that immediate loading is not also important, the primary stability of the implant in terms of insertion torque, but more important is to know the configuration of the implant abutment connection. In order to explain to you this, I have some examples for you in the next few minutes. We compared now patients who have been treated by me in my private practice in Europe, 15 patients, 6 implants in the maxilla with augmentations. And when I moved to US at NYU, 10 patients in collaboration with my students, 80 implants in total, 8 implants per jaw. And you see here, after a loading period of more than 2 years, we have a very high success rate. So let's look at this example. In the anterior mandible in this patient, after extraction and 4 months of healing, I was able to place the implants in conjunction with lateral and vertical augmentation, and we used autogenous bone and GBR in the principles of GBR, as always, you know, with a very good rigid immobilization of the membrane using titanium tacks. When you load these implants, if you follow the protocol of the standards, you should wait for 3 to 4 months. But in the reality, the soft tissue heals within 6 to 8 weeks. Then I was very careful with my second stage surgery. I uncovered the implant after 6 to 8 weeks, and I was able to finalize a telescopic retained implant supported restoration, fixed detachable. And now please observe the bone levels, the crestal bone loss after 2 years and after 18 years. And if you compare this situation with cases what we have in our practice, when you remove the abutments, when you graft with different grafting materials and you keep delayed loading protocol, you lose bone. And here I have much better condition for my patients, and also from the periodontal surgical standpoint, much better conditions. But let's look at this example. What happens with the wine stoppers or bottle stoppers, the covers of the bottles, if we have a bottle of oil at the left, where we have this kind of mechanical connection or a press fit connection here with the cork of this bottle. And what happens with the conical shape wine stoppers in the more tapered connection? We need always to have a higher force at the left side, slide here at the external hexagon. We need less forces using here press fit connection, and much less forces when we have more tapered conical connections. And this is exactly what we know from physics. When we increase the connection or the angle between the abutment and the internal part of the implant, we reduce the stability. In other words, we need to have a higher torque in order to stabilize this abutment. And if you place an implant and you have to deal with bone grafting simultaneously, or you place an implant in the soft bone, in the weak quality, bone quality type 4, then you have a problem to stabilize the abutment because the implant is spinning. Therefore, my key for success is the conical connection. And you see, my friends, what happens here. When my daughter was 2 or 3 years old and she put her, actually younger, and she put her finger in the bottle of milk with a conical shape of the finger or press fit type of connection, she was not able to remove her finger from the bottle. Did this child have a high torque or high force? Definitely not. So what we need now to do, if we deal with a dentulous, let's say maxilla, like in this case, where we have to deal with augmentations in the maxilla left side with sinus lift procedure, and in the right side, lateral augmentation and vertical augmentation with corticocancellous block, which we milled here with a bone mill. You see after GBR, and in the left side, after sinus lift with window and GBR, I was able to place my membranes, to immobilize the membranes. And after 6 months, we had this bone in the CBCT, and at the left side, much more bone. And in order to keep this bone, we need to load these implants after placement immediately after surgery. The restorations occurred in the prosthodontic department here at the University of Rochester in New York. And here you see in the dentulous mandible, after I placed here these implants, I was able to augment with autogenous bone as a sandwich technique after I used my abutments. And in order to improve the bone around the implants, we placed as a sandwich, as I said, before autogenous bone and maybe an allograft or a xenograft later on and a membrane. The implants are loaded immediately after surgery with a hybrid prosthesis, and this is the result after delivery of the restoration from the prosthodontist and the 2-year follow-up, which shows here crest of bone stability in the maxillary implants, around the maxillary implants and the mandibular implants. But what happens about if we have to deal with immediate implant insertion and immediate functional loading? This patient lost all of the teeth due to periodontitis, severe periodontitis, here stage 3 and 4 or 4. And then after extraction of the teeth, we were able to place implants in the residual sockets to graft these implants, the peri-implant areas with the autogenous bone from the other sides in the jaw, and then to load these implants immediately after surgery. The difference between maxillary and mandibular implants was chronologically 2 weeks after. So we started with the maxilla and 2 weeks later with the mandible. And these are the abutments, which are custom abutments, prepared very, very thin from the technician in order to improve aesthetics. And if you observe after 2 years of loading, this is the restoration in place. The soft tissue grows nicely around these implant abutments and the patient was happy. But please observe what happens to the bone over a period of time. Radiographically, we don't see any bone loss, at least mesiodistally. And if you evaluate now what happens after 5 years, you see that we have some kind of resorption in the canine region. And if you look radiographically, this resorption is not visible in the panorex. But if you continue to observe the patient over a period of time, you see here how these implants look like, how the prostheses look like, and the situation has been stabilized after 5 and 8 years. And the patient now is with the same situation after 15 years. Now, what happens if you have a very old patient who loses 2 teeth due to long fractures, and the patient is not able to come to the office multiple times, or the patient, because she comes from a nursing home, cannot use here different partial prostheses? We extracted these 2 teeth and we placed immediate implants without opening a flap. And in the residual defects we had, we used you use allografts in order to have also induction and also conduction. But this bone has to be also remodeled. And in order to get the remodeling, after subcrestal placement, as you see, placement of the abutments, which we never removed, we see radiographically the crest of the bone in an ideal situation. And after 1 year, the bone is growing over the platform. Please, my friends, do not forget, using my concept of subcrestal implant placement, immediate loading, platform switching, and also one abutment concept, I have long-term success. But what happens now if you have to deal with the vertical augmentations and GBR technique? And the first speaker today, Dr. Wiedemann, mentioned about the problems we have with the nerves. And also Dr. Pai mentioned as a second speaker about the bone resorption. The concept I recommend you here is after you open a flap, you evaluate the anatomical conditions, the foramen mentalis here. In this specific case, we decide to do autogenous bone graft in combination with xenografts, the membrane in place, and we close the flap without tension. And when would you like to bring this patient back to your practice in order to place the implants? Some people say after 6 months, some people say after 1 year, some people say, I don't know, some other people say less. But look what happened when the patient came back, and this is very interesting case, that's why I present in our group, that even we had a xenograft and we did not have any complications with the healing, after 1 year we had a complete resorption, at least in the height. Now the patient asked me to avoid new grafting, to avoid to lose the canine, and to think about additional or alternative methods. And then we discussed the pros and cons, and we decided to do a nerve transposition to place the implants and at the end to place the abutments and immediate loading. And then the bone was able to be stabilized. Therefore, loading of the bone seems to be very important. So now you see in the posterior mandible what happens if you have a segment and teeth are missing, and you graft here, for example, only with allograft, not autogenous bone. You flip over a membrane, but this membrane is absolutely stable with titanium tag stabilized. After 5 months, we were able to place implants, but the question is, what do we do in order to avoid to have bone resorption? And now here, I place the implants, I place the abutments, I try to place subcrestally. However, this implant design has not platform switching. And because of the lack of platform switching, it's very difficult to engage the abutments. But if you do that carefully, it works well. And then the provisional restoration is only there, not for aesthetic purposes, but only in order to have a little bit loading forces of these implants. And these are the implants after placement and the delivery of the prosthesis immediately after surgery. And the situation looks like you see here radiographically after 4 years. Or in this area of the posterior mandible, if we have to deal with a defect where we have to do vertical and lateral augmentation here with allograft, we were able to find the correct level of the bone. And in the ideal case scenario, I try to over augment. And certainly that's why we are surgeons and we train surgeons. We must be able to advance the flap in order to be able to avoid to have tension. And this situation was preoperatively, and this situation is after a couple of months. And you see radiographically, there is no big difference in the radiograph, but in the reality, we have big difference clinically when you open the flap. And now we place the implant in the abutment and we load the implant immediately after surgery. And when do we take the final impression without to remove the abutment? 6 to 8 weeks later, we are able to remove the prosthesis, which has been placed and was here cemented with Tembond, provisionally in other words, and then we were able to take the impression and to finalize the case. Or in this case, with a single tooth implant, which has here a huge defect, if you want, in the height and in the width, you see what would you do in this case if you have to place an implant? The patient doesn't want to have a bridge. We do a vertical and lateral augmentation, relatively minimal invasively with allograft and a collagen membrane immobilized here with tacks and flap closure. Initially, I expect to have some kind of resorption, almost 30 to 40%. But in order to stabilize the bone resorption, I place the implant after 5 months almost, and then we are able here to have this bone growth. And after 6 months, we have this bone when we place the implant in this particular case, and we have the provisional restoration. And at the end, I'd like to show you immediate implants, immediate loading, and sinus lift procedure. And in this case, you see, we place the implants as immediate implants here after extraction of the teeth, provisional restoration in place with bilateral sinus lift, the situation here after 8 months with a telescopic retained prosthesis, and the radiograph after surgery. And 14 years later, not 14 months, the patient shows to us in the Panorex this bone growth. One of the final case where implants were placed and were also integrated, placed in another country, and all of the implants had to be removed except these implants at the left side of the mandible. The patient was relatively young. I removed the implants step by step, first in the maxilla, placed implants with abutments immediately after surgery, augmentation with autogenous bone and a xenograft, provisionalization in place in occlusion. After 4 months, we were able to go to the mandible and we placed the implants after grafting. And 3 months later, you see at the left side, we go ahead. Provisionalization will be done after the implant placement. And Dr. Wiedemann mentioned specifically the anatomical pitfalls, preparation of the nerve, and then after 6 months of bone grafting, we were able to place the implants and to provisionize the case. The patient was very happy, and the prosthodontist, Dr. Palermo at that time, made the restorations, And this is the radiograph and the clinical picture after 1 year. So the patient actually is at the US Air Force, and he is somewhere around the world, and I was not able to see him. And he sent me after 6 years the radiographs from a camp where he was for cleaning of the implants and teeth. He lost his crown at the left side, which was done before, but the crest of bone is, as you see, almost solid. And at the end of my presentation, my dear friends, dear colleagues, I'd like to show you that there are many papers on this specifically topic, but not many studies in conjunction with autogenous bone or other grafting materials. The requirements for the success are the sufficient apical stability during the attachment connection. The sufficient patient compliance is very important to have patients who follow your rules. The suitable diet protocol, which has to be 3 months for the advanced protocols, at least 3 to 4 months after implant placement, and 4 to 6 weeks without grafting. And last but not least, a team approach, which is very important in general, as you know, in implant therapy. All of this, what I present to you today, and I'm sorry there is a little bit delay, but we had some kind of technical issue, has been published in the 2 books by Quintessence. First, the posterior mandibular implants in humans and animals, and the advanced immediate loading with all of the different protocols I present to you today. And I'd like to thank you very much for your kind attention. Best wishes for the future of the Academy of Oral Surgery. And please keep me in mind in case you need my support for our members. Thank you very much.
Good morning, friends from all over the world, and welcome to American Academy of Oral Surgery. Here we have Stefan Levin from the Schwarz. They're very famous and very old instrument company from Germany. Welcome, Stefan.
Hi, good morning, good day, everybody, wherever you're watching. Hi, Dr. Javid, thanks a lot for being here. Shortly today, I wanted to introduce our company Schweikart. We are producing Schwert instruments. And for that, I have prepared a small PowerPoint presentation with some information on it, with which I'd like to start. And to give you some dates. We are a company Schweikart. We are a manufacturer of dental and surgical instruments located in Germany. First, I'm going to start with some general information. We are the as mentioned, manufacturer of dental and surgical instruments under our own brand, Schwert, which is the German word for sword, so a weapon. The company was founded in 4th May 1896 by Mr. Albert Schweikart in the former heart of Tuttlingen. And in the next year, we already have our 125-year anniversary, especially in May. And we are located in Zeitingen-Oberflacht, which is a small town in southwest Germany. You can see it on the map on this very end of the arrow. There we are located right in between Zurich, the Lake of Constance, and Stuttgart. Some general information: 2009, the company was relocated in a way of taking up production steps, making everything better, planning, etc. And we prepared a new production and office site in Zeitingen-Oberflacht. And also the production building was expanded to have a lot of more capacities there available for being in a better position to produce more and better instruments. And today we are exporting to over 60 countries worldwide. And on the bottom left, you can see the production building as it is today. It's not the complete building, it's an extract where we have a lot of machines and approximately 10,000 square feet production space, where we have a special drilling and turning department, as you can see on the bottom right. It's just a small picture. And our instrument range, contains about everything, I would say. Of course, we have our specialties, but in general, we have a complete dental range of products, which covers all the disciplines like extraction or implantology, of course, periodontology, all surgical things, especially microsurgical instruments. There I will also show you some specialties after the presentation. Of course, we are there in the restorative and conservative treatments, and also we are in the prosthodontics, having our strengths. Go on. There, just to give a brief idea on what Schwert instruments look alike. On the left, you can see a P-Lux, which is an atraumatic extraction instrument. It's a luxator. We call it P-Lux because it is held like a pencil, therefore pencil luxation. We are having, of course, extraction forceps. Here our tech traction design. The name is already having some features in its name. It's like a tactile traction, so you have a very good grip on the instrument, a good feeling while you are extracting the tooth. One of our special needle holders, I will show that in detail. And of course, a composite kit and some curates, especially for cleaning the teeth, and our Safex, which is also an instrument which I will present in a minute. Sorry? Oh. So where should we start again? Sorry.
We weren't able to see the slides, so we're seeing it now, I guess.
Good. Sorry.
Perfect, thank you.
The first product which I'm going to show you is the P-Lux Periotome. That small guy here. First of all, of course, a periotome is, everybody knows a periotome for cutting the ligaments. But what is always a problem? We are having a very sharp instrument. A sharp instrument needs to be thin. And of course, a thin instrument can easily also break off. But with our new instrument, with the P-Lux periotome, that issue isn't a problem anymore. We are having here a very, very special steel combination inside of the tip, which allows a very good power transmission and also to bring force on the tooth, especially at that state when you have already loosened all ligaments or cut off all ligaments. You can pretty good begin to luxate the tooth. Just to show you what the tip is able to cut off, I will going down a little bit with the camera to show you something here on the desk. If you see that, you're having here a blade which can pretty good bring some power and which will not break. As mentioned, a lot of those instruments which we've seen in the past broke during a luxation or because somebody would like to give the tooth a little kick and just broke off. With that instrument, that will not happen anymore in the past. And in the beginning, as I told, this is what I mentioned with the P-Lux handle. It is like a pen, and you can easily hold it like a pen and work especially like that. If we're talking about a model here, that is exactly how you can do. Just need to look what I'm doing. And you have here a very good access to that, and also it's good to work. The next product I want to introduce is especially for everybody who is doing a lot of surgical treatments, in my opinion, an absolutely must-have. It's in the first glance, it's just a blade holder. But of course, always when we are talking about a blade holder, what is the most important point? The safety. Don't cut. If you are getting cut, or if you cut yourself, there are several things which are important. You need to do a lot of blood testing, etc., etc. Always a high risk with contamination, diseases, etc. Especially when it comes to switching the blade, then it's always a problem. With that instrument, though there is no problem anymore, I will just let it speak by itself. If you need to remove the blade, go over to your container and just use it like a pencil. By just pushing the button at the very end, you can easily drop the blade. For putting off, or better said, for mounting, there is no patented solution, but here we are having a patented solution. Just easy. Easy to put that blade off. We got technical issues. All right. The last instrument I introduced it as a Castroviejo needle holder. You may know, of course, the regular ones. The special here, or the problem is always within the joint. As I'm here in a big group or talking in front of a lot of surgeons, I am pretty sure that most of you had the problem that the suture is getting stuck here sometimes. While you are doing the knot, the suture can get stuck inside here of the joint. And one of the biggest problems, of course, is then if you close it by accident, the suture can get cut off very easily. And of course, that's not a good thing. You want to save time because time is money always. And therefore, we created a brand new design since a few years already, but it's not so well known around the world. Therefore, I'm showing it here. We are having here a so-called twist design. The main difference is it is not produced anymore in a forging, but these two pieces are coming directly from our turning machines, the machines which you saw in the beginning. And here, by the opportunity having that twisted design, it is impossible to get the suture in there. It is very easily, while you are doing the knot, closing it, and then it's just smoothly sliding away. Not doing anything else, it's just sliding away and you don't have that problem anymore. This is a problem, a product, sorry, which we are having in a Castro Viejo design, but which we are also having in a little bit heavier design, which gives the user the opportunity to use a little bit of a bigger suture. With that needle holder, we inform to use a suture 50 to 80, but with this bigger one, there's also absolutely not a problem to use a 40 to 80 suture, just to give you a little bit of more flexibility during the use. For products, and because, as I don't want to be here without bringing anything to you guys, we are coming here with a Global Summit special offer, which means we offer you a 15% discount for all email orders with Global Summit order as a subject. Please send them to our email, contact@schwert.com. You can refer them to me already, also with the name, it's absolutely not an issue. I will take care of them. And all the following information we will send by email with an order confirmation. Probably if you're having a distributor in your country, we will get in contact with him to solve it over them. And of course, if you are in a specific country where you say, there is a distributor which needs to know Schwert instruments, show him, let him know, let us know. Would be absolutely a pleasure. And if you are interested in seeing more of us, you can, I'd like to invite you to visit our homepage under scrhwert.com, or follow us on Facebook with Schwert Instruments, or also on Instagram, Schwert Instruments Official. And I'll be happy to see you there to get your inquiries. And of course, if you have any questions, always let us know. We are here for you. We are your partner worldwide. And that's so far the presentation from my side. And if there are any questions, I'm there. Please put them. Or
Well, welcome. And first of all, I really appreciate Dr. Javed and others allowing me to provide an opportunity to share some information with you on this inaugural meeting of the American Academy of Oral Surgery, and to also create some interest in this whole arena of implant disease. When you and I think about implant disease, it really comes into basically two categories, at least at this point. You're going to hear me speak that actually there may be even more categories of this. But in implant disease, to be fairly straightforward, we have implant mucositis and we have implant, what we call implantitis. And in doing that, we need to possibly take a look at where we are with these two groups. I am Sam Lau. I am at the University of Florida, College of Dentistry, also the past president of the American Academy of Periodontology. I do a significant amount of work in some other areas. I helped start something called the Florida Probe, which is now VoiceWorks. You'll hear me speak a little bit about PerioSciences, the only antioxidant gel out there to support management of implant disease. BioLace, naturally, I am the Chief Dental Officer for BioLace. Philips, Sonicare, and Hu-Friedy/EMS. We have three primary areas within our time period that is critical for me to ensure you as the learner of the directions. One is developing how do we determine the difference between implantitis and mucositis, and even how to manage it. Two, looking at techniques for non-surgical anti-inflammatory biofilm control with innovation technology that can be lasers, that can be what we call air medicinal delivery. And then lastly, really focus on the implantitis part, on the decontamination of implant surfaces. And I want to afford you some very interesting dynamics of basically what we're thinking as the etiology of implant disease. Implants are not new. They started back 2000 BC. You see the Egyptians use shells and ivory to replace missing teeth. And there's no doubt that in that 51 to 65 with Dr. Brånemark, he truly opened up this whole area of endogenous root form implants, and that never stopped. And now we have moved to different implant surfaces. We have now, as you are aware, the All-on-4, All-on-6 has been adopted by many, many dental practices. But probably what is sort of left out of this equation is that even though in the US, we may be placing 2.7 million implants a year, and it is a 6.5 billion industry, do all implants succeed? And the question is, if they all don't succeed, how can we increase the number that do succeed? And so we now are focusing as much on placing implants and the services of implants, but now we should consider focusing on maintaining implant success. One of the areas is that you cannot compare a tooth and an implant. That would be very naive and myopic. A tooth has so many other structures, and that affects the pathology. The implant has fewer structures. It has no periodontal ligament. It has no cementum. It has bone, but it doesn't have those supracrustal fibers that are attached. In fact, all we see is adherence. So naturally, there are complications with implant placement. And I'm here to suggest to you that there's many complications on the prosthetic side as there are on the, what I would call the perio implant side. We have fractured screws, fixture loss, naturally oral hygiene, soft tissue reactions, broken attachments, fractured components. And you and I both know that if you've been in this implant business long enough, these things will eventually catch up with us, and they are. I placed my first implant 20 years ago, and I wasn't the first. So we have at least 3 decades of fairly focused on implants, and that implant placement is increasing every month as we speak. So we try to sort of throw things out as what causes implant failure. For a while, we went through the whole cement game and not taking anything away from the cement game. But now we're going towards what? Many, many more screw retained prosthesis. So this may be something of some implants and in the past, but moving forward, this will be less and less and less. So here in the upper left, you see some extruded cement. And here in the lower left, you see after remove that cement, actually remove that with a laser. So none of us likes to see this. This is significant, and this only enhances what I call a foreign body reaction. And so therefore, it's not that I don't want to discount the possibility of cement, but cement is not as much as a primary etiology as we discussed in the past. Now, naturally, my association with the American Academy of Perio, and to a certain degree the Euro Perio Federation, I always go back to what's written. And you may be aware that in the 2017 and move forward into 2018, both groups created a new classification of periodontitis and gingivitis. But this time, implant was brought forward into the classification. And you'll notice that there are 4 bullets with that. There's peri-implant health, there's peri-implant mucositis, there's peri-implantitis, which is bone loss, but also there's a 4th bullet. It's called hard and soft tissue implant site deficiencies. And this is caused by, well, they want to say natural healing, but extraction trauma, infections, a variety of other areas, including misplacement of implants. In other words, geographic. And I don't mean countries, I mean not placing the implant where it should be in the osseous. We're now starting to even think about how we graft extraction sites may be a factor on implant survival, in that if these grafting materials are not appropriate, they could also be a foreign body reaction that we're just not even aware of. And so we have really, for the sake of this conversation, 2 primary implant diseases: the peri-implant mucositis and the peri-implantitis. To me, the peri-implant mucositis is almost like the gingivitis of implants. The peri-implantitis is when you actually see the loss of bone. So let's speak first of all about peri-implant mucositis. Now, you might ask yourself, why would I put such an emphasis? Why don't we just take this whole presentation and get down to the implantitis part? Because I am not so sure we are managing mucositis. Generally in the United States, and to a certain degree Canada, mucositis is managed by a dental hygienist. You're going to see here in a moment that I'm not so sure that we have what we consider to be the playbook, the standard on how a dental hygienist or a dentist even manages mucositis. And I'm of the degree that if you don't manage the mucositis, there is that possibility that it can at sometimes move into the implantitis, just as we see that correlation between gingivitis and periodontitis. So as we take a look at this, you'll notice the tissue response. The 2 anterior implants, they slightly have inflammation, but notice the 2 distal implants have substantial inflammation. Inflammation is the result of a stimulus. I think we sometimes forget, we call everything an infection. That would be myopic. An infection may be that which initiates, but it is the host response to the etiology that literally creates the tissue destruction, both hard and soft tissue. So if I go back to the classification and they looked at every study, notice that group suggested that there are really only 3 etiologies to mucositis that you can hang your hat on. 1 is naturally biofilm, 2 is smoking, 3 is radiation. The other areas are possible, but not direct. And that is diabetes, one of my favorites, lack of keratinization. You probably saw that on the previous slide, and the presence of cement. So when we take a look at that, the diagnostic criteria is how do you, in your operatory, determine if you have implant disease? Well, yes, you should probe. I don't care what you probe with, but I'm suggesting you should probe only for reasons of determining where the bone loss might be, especially in a two-dimensional, or determine suppuration, or determine to a certain degree hemorrhage. But trying to do measurements around many of these implants, if you cannot take the crown off, the implant support restoration off, I doubt seriously you're going to get an accurate number. So I use bleeding suppuration and radiographs. But radiographs have to be very standardized, as you know, or we will not get a true depiction of where that osseous is. And then naturally evaluate the occlusion and the prosthetic stability, remembering that 50% of these issues are related to prosthodontics. And then naturally the attached gingiva. So I'm not suggesting using plastic probes because you may hurt it with the metal probes. That's the least of my concern. I'm suggesting that you do probing with plastic so that you can get around the convexities of many of these types of issues. And here is a good example of the problem. If you have a large convexity that you see over on the left, you being able to try to get around that is almost impossible versus taking the crown off, which may not be feasible, to where now your probe can be more parallel to the long axis of the implant. And so attached gingiva, again, is one of my pet peeves. I just do not understand why, in case there's just no other way, that we would want to place implants unless it's in keratinized tissue. Because eventually we're going, and now we're starting to see more and more studies that are showing the relationship between the two. I'm not going to go into a great deal on the oral hygiene instructions, but to suggest to you that some of them are just not realistic, including floss. In fact, there is a study that demonstrates that on groups of patients that use floss, there's a good chance that the floss is going to tear, and it also becomes a foreign body reaction. So with this, all I can suggest to you is this: maintain simplicity, use good common sense, and use the biggest thing you can find to get underneath there. Now, if you say to me that water irrigation only is effective, I will say to you that is not true. You can follow with water irrigation, but you've got to mechanically remove biofilms. You are not going to be able to increase the pressure on these devices to the point to truly disrupt biofilms as you can with mechanical entities. So naturally, as you're creating the prosthesis, be thinking about, can the patient actually maintain it? And these are some of my most favorite. I love things that are like these interproximal brushes. This just happens to be something like a soft pick from Butler. Intuff brushes, interdental brushes are phenomenal for this. But we've got to have control of the biofilm. And please, would you get these patients on electric off manual? And again, one of my favorites is this Sonicare Air Floss, because you can literally put medicaments in their full strength in this chamber, and then it shoots out with this. It's almost like the Tesla of oral irrigation because it has a lithium battery in it. But I highly, highly recommend something like Air Floss. And again, this is that antioxidant gel that I was discussing with you. This is Periosciences. This gel is phenomenal on biofilm, xerostomia. It's very natural. Thousands of practices are using it. It's got antioxidants, menthol, thymol, essential oils, and xylitol in it. So if you're able to get this, this is all what we use on all of our post surgeries and on all of our implant patients as far as maintenance of those implants. and that is periosciences.com. So now let's go to what that dental hygienist or you may be using. And there are many studies on what to use non-surgical. Studies with Frank Schwartz and others. But notice at the very bottom, and I was actually just with a doctor who saw an implant issue and used antibiotics on a small area that had suppuration and a fistula tract. And I said to him, I know you've already done it, but please in the future, would you be just cautious about just using antibiotics in periodontics in general? Because most of our studies demonstrate that it has no more effect than when we do traditional modalities. So the point is, I would bet you 90% of dental hygienists yesterday on Friday in the States probably picked up a manual instrument trying to do something with an implant. I hope, and this is not very scientific of me, but I'm just going to suggest to you, this is ridiculous. You cannot disrupt biofilms with a device of this nature. It is impossible. And most hygienists are frustrated about it, but that's what we give them because that's sort of all that we have. But what we are seeing is that when you use devices, including ultrasonics, on these implants, two things are occurring. First of all, look at the scratches that is occurring on these implants. And secondly, the release of titanium oxide, we'll talk more about that later, into, especially if there's inflammation, creating a macrophage reaction. So now we have studies, 2017, ultrasonic scaling of titanium implants releases particles that not only vary by surface type, but aggravate periimplantitis. Okay, and that's from this whole macrophage thing. So I wish I could give you some alternatives, but I've looked at every possibility. And those possibilities lead to air medicinal biofilm control of implants. I don't care what device you use. There are some companies out there. But you do need to consider that you or your hygienist in maintaining implants have got to now go to something like erythritol or glycine particulates. This is not, by the way, this is not sodium bicarbonate. But to go down to some of these units, one of my favorites, as you see in the lower right, is the EMS Prophylaxis Master, where you have both the piezo and the airflow delivery system. But I will leave that up to you because look at the result. Okay, here's our patient coming in. Now you see, notice on that, the one for me on the left of this no attached gingiva. I see this so many times. You know, all on 4, all on 6 says, please, we gotta have attached gingiva. But look what happens after 45 seconds total of using an air medicinal delivery system. So if you look at that, 45 seconds later, the beauty of being able to disrupt the biofilms with air medicinal delivery systems. And again, it does not matter to me what you use, but make sure that the powders that you place in these devices are the glycine or the erythritol, because they work exceptionally well, and you'll see it. You just cannot believe how clean these implant and prosthetic surfaces are when you do this. So my point is this: I vote for now moving forward that all implants placed must be maintained with some type of air medicinal delivery systems. There is nothing else that even comes close to this. So now, as we move into the second part of our program, let's you and I discuss the implantitis part. If you and I look at the implantitis part, I hope that you can appreciate that we are in a new era. An era by which, when you look at implants, the osseous topography pathology is not the same as periodontitis. You do not see with periodontitis these large wells of 2, 3, 4 wall pocket infrabony destruction way away from teeth. You just don't see it. And I think I know why. It is because from the host point, the host is able to somewhat contain it because the only etiology is possibly the biofilm. Some of us are beginning to think that with implants, the reason that you see so much host reaction far away from the implant is that there may be something in the granulation tissue that continues to perpetuate that inflammation. And for some of us, we believe that's titanium oxide released. The words corrosion is suggested. And if you've been in the implant business long enough, you will see an implant be very stable for 10, 15 years, and then within a year, look like what you see on the screen. So it is difficult also to look at the implant diagnostics. You know, for us in perio, two-dimensional radiographs pretty well work. Why? Because most disease is interproximal. About the only time you and I see anything on the buccal, lingual, or palatal is going to be a fracture or a furca. With an implant, it is like furcas on steroids. So you'll see as much destruction on the buccal as you will see in a proximal, and that then does what? Messes up the diagnostics only using radiographs. And that is why when you see something of this nature, you're not using your periodontal probe to actually measure numbers. You're using your periodontal probe to try to look at the topography of the implant surface. This just began the start of it in 2014. This is an article by a PBRN network in the Journal of American Dental Association suggesting 18.7% of all implants are classified as failures. That number is now approaching 20 to 25% because we're placing more implants. Some of us are placing them that probably should have more training. But when you look at the etiology, the primary etiology is the placement of implants in a patient that lost their teeth from severe periodontitis. It doesn't mean that we won't place those implants, but maybe in those particular patients, they have a high risk. We need to be thinking about that. So I got this from Dr. Stu Fromm in New York. He's actually wrote the book on managing implantitis. And so if you look at this, look at the number of implants sold. And what Dr. Fromm was suggesting is if even just 10 years of these implants, 10% of these implants were lost, that would be 273,000. And if you looked over 5 years, that would be 1.365 million implants lost in 5 years. So his son, Scott Fromm, had this in the Journal of Dental Economics, in which he actually put it to money, demonstrating that in Manhattan, it's 6420 to actually place an implant and restore it. But if you have to remove the implant and place another one, it's $8,700. Now, if you add that to the $6,400, what's the bottom line here? First of all, try to save teeth. What's the second bottom line? Secondly, try to save the implant, because the repercussions are not like just having a tooth removed. It's substantial. So why are these implants failure? I will tell you, we sort of don't know. We have some ideas, but it could be plaque, biofilm, nicotine, lack of attached gingiva occlusion, size of the implants, anatomy. But let's go back to our classification in 2017, 2018. Just like I did with mucositis, the history of chronic periodontitis is definite, poor oral hygiene, no regular maintenance, And the possible indirect was smoking, cement, attached gingiva, positioning, etc. I would ask us, do not forget about occlusion with implants. There are now becoming more and more studies demonstrating the relationship of occlusal overload with peri-implantitis. And then there's placement issues. I'm sure you're probably asking yourself, what were they thinking when these implants were placed? I wasn't there, I am not sure. But the bottom line is, whether it be implant proximity or just not being placed appropriately, we do have these issues. So in the risk factors of implantitis, we're now starting to appreciate that there is something way, way, way beyond just simple biofilm. There is something else going on in these arenas. And look at the well and the loss of bone around this implant. So therefore, we begin to look at surfaces of implants. Now, I wish every implant was machined, but then it would not integrate. So you want this, but you don't want this. You've got to make up your mind. So what do we have now for most implants? We have machined, and then we have a surface to where it's porous, anodized, however, to where now we can get the osseointegration. So as long as we stay in the machine part, life is easy, as you see in the lower left. But once you get past the machine part and you get into those areas that are porous, whether it be SLA, calcium phosphate, or even anodized, you can imagine as the bacteria gets into those areas, then we can have an acceleration of the implantitis game. And so here to me becomes one of the, and by the way, as I'm doing this, I'm going to give you my email at the very end. If you want this presentation, I'll be more than happy to send it to you. But what we're finding, and this is the landmark paper for me, it's by Tom Wilson and group in January 2015, Journal of Periodontology, in that they are suggesting that titanium and dental cement are foreign bodies. And then the word corrosion begins to come about. So we're right on target. Let's talk about how to manage now implantitis, as we talked about mucositis. The number one way to manage implantitis is, and maybe, is to open a flap, visualize it just as if it was a tooth, and then do something. So it's surgical flap access, resection, and we've got individuals that have, we've got multiple studies now, like the starting all the way back in 2003 and earlier, on opening these cases up and doing something. I'm going to probably say it again, but I want to stop right for a moment. We have got to stop waiting till we have lost so much around the threads that now the prognosis is extremely marginal. You do not see as much linear inflammation over time as you do with periodontitis. This is logarithmic in implantitis. And primarily why? Because again, you have threads that are like furcations on steroids. So I am screaming from the top of the mountain, quit waiting. When you first see bone loss, you need to intercept. Because once it gets into that first thread, then you have very difficult time reversing it. And so now we see implant contours and surface are a limitation to remove the biofilm. And now you begin to see some folks begin to talk about lasers. And so therefore, again, here is Dr. Fromm, and he and Paul Rosen, his colleague, here they're discussing what they consider to be a fairly straightforward way of doing this. And that way is this. And I must tell you, it's 13 steps. And it's amoxicillin and full thickness flap and air power abrasive, although I would not use bicarbonate. Sterile saline, tetracycline strips, second application. Now you're putting chlorhexidine, and now you're putting in sterile saline and Imdagaine, and then BioWash or PureWash and Osix membranes, and et cetera, et cetera, et cetera, et cetera, et cetera. And here's a great example of that. And that's how you get up to $6,000, $7,000, $8,000 in repairing these kinds of things. And you've been down that path. We've used hydrochloric acid, tetracycline, EDTA, hydrogen peroxide. And I am going to introduce you now into possibly the use of lasers. Now, I've done this. God be with you. And the other issue with doing implantoplasty is that you are releasing all of those implant particulates into the tissues. So I still know that in Europe, this is still a possibility, but for me, it's not on the chart. This was a good idea. It's not on the chart. So let me close and talk with you about lasers in my remaining time. First of all, you cannot just use any laser on an implant surface. You cannot use a diode. And personally, I don't think you can use an Nd:YAG. You can only use an erbium or possibly a certain kind of CO2. But everything else will harm the implant surface. These are untouched photos of melting and cracking that occurs when you do use a diode or Nd:YAG on implant surfaces. It's because of thermal. And what a study by Yamamoto and the Nevins group showing on the right, bone coming into the threads when you use an erbium laser, and over on the left, no bone in the threads because the laser is detoxifying. And another article, International Journal Peri-Restorative, by the same group, I mean, just phenomenal detoxification of the implant surface. And here, if you're going to really want to look down into those implant surfaces and see what lasers can do, Straver, Journal of Perio, 2016, the erbium chromium YSGG laser with a radial firing tip was able to remove 95% without having any effect on those surfaces. So I am an erbium fan, and I have been that way since 2008. I have more predilection towards the erbium chromium YSGG than the erbium YAG because of its absorption further into water. That means deeper penetration, but I'm going to leave that up to you. But the beauty behind all of this is a handpiece that you can get in and operate with. And you'll notice that this handpiece is very much like a high-speed handpiece. And so therefore, when we do that, we can get these kinds of results. They're not perfect, but I'll tell you what, we're not going to lose those implants. Would you agree? And this is how we do that using erbium chromium YSGG lasers. And not only have we done that, some companies have created special tips that literally go down and into the implant and literally go into the threads and detoxify the threads. And this is a great study by my colleague, Chris Walensky, in which he put very, very detailed, impactful, tough cement, implant cement and threads. And look what happened in just a matter of 20 or 30 seconds. And the reason for that, by the way, is that there's water in cement, which is also why you can use erbiums to remove veneers and zirconium crowns in 30 seconds to 2 minutes. So with this, we're doing bone decortication. And so I would suggest to you that it's not just the anecdotal of many, many, many practitioners out there that are using erbium lasers. We now have studies. And I move you towards a great study by Don Clem and Jack Gonzalez, peri-implantitis treatment using an erbium, they used erbium YAG, and bone grafting, a prospective consecutive case series. It is outstanding. And it shows you that using these lasers to detoxify the surface, and then in some areas coming back with your osseous augmentation and your biologics, that you can achieve the halt of implantitis. This article just came out, this last week, in the International Journal of Peri and Restorative Dentistry by our friends Ron Nevins, Stefano Parma, and etc. David Kim over at Harvard. And here is one of the first human histology evaluations of using the erbium chromium to decontaminate an implant surface. And my goodness, human histology that you see over on the right of your screen, these lesions were almost to the apex, and they were able to get regeneration of the osseous. Now, in addition, they did use freeze-dried bone, and they did use GEM21 biologics. But it shows you what we can do now in preventing this. So in conclusion, no matter what you do, there are three things that are critical. You've got to degranulate, you've got to detoxify, and you've got to decorticate. I absolutely believe that erbium laser is and will be the state of the art in managing implantitis, because I know of nothing that can do it as effectively as degranulating, detoxifying, decorticating. For my US colleagues, you are aware, I hope, that there are several codes out there, including D6101, D6102, and please, so do not do this for free unless you place the implant in the last 2 years. So when we discuss this, let me give you some thoughts. Early detection is absolutely critical, and I'm telling not you on this, but for the world, please quit watching and waiting on mucositis and implantitis. I actually have my friends, colleagues now using the laser erbium for managing very inflamed mucositis. Why not? Access to the implant by both the hygienist and the patient is absolutely a necessity. What you use on the tooth is not what you can use on an implant. They're very different. And please, we need research, we need evidence, but this thing is not just about biofilms. So with that, this is my email address. We are colleagues. Anything I can do to help you. If you would like a copy of this presentation, please email me at slow@dental.ufl.edu, and I'll be more than happy. Again, I really want to thank Dr. Javed and others for allowing me to be part of this inaugural annual meeting, and wish this, as George Romano says, wishing this group very good success moving towards the future. Thank you.
Hello, everyone, and welcome to the American Academy of Oral Surgery Symposium here. We have here with us Luke Soini from BioLace. Welcome, Luke.
Thank you, Dr. Kayvon.
It was an amazing presentation on the laser and basically peri-implantitis by Dr. Lau. So obviously you're presenting the company. My personal experience, obviously, with BioLace is, as you know, I've been using it for many years, and I have it pretty much in all of my practices, and I use it routinely. And as you know very well, I'm not personally using it for restorative dentistry. I'm using it on all, implant-related surgeries. Biopsies, tissue removal, and all that. So go ahead if you want to give us some, introduction, if you have some, to your different units or what's available for the doctors.
Yeah, absolutely. I'm gonna see if I can just kind of pull up my presentation here and share my screen.
So I know your latest laser machine right now is your Express unit, which is
Correct.
very affordable. And
yes, yeah, we have several Waterlays. We have our flagship, the Waterlays I+, and we have the Waterlays Express, and then we have several diode lasers. We have the Epic Pro, we have the Epic X, which can do in-office whitening as well with our proprietary gel in 30 to 45 minutes. We also have the TMJ handpiece, which is extraoral to help with TMJ and TMD pain. And then we also just launched our Epic Hygiene platform because the Epic X was so popular. We stripped away the whitening and the pain therapy handpiece, lowered the power, and we created a laser for hygienists by hygienists that actually created this. And there is a phenomenal practice guidebook that Dr. Lau and team came up with as a step-by-step integration of a diode laser in your hygiene operatory from start to finish, from when the patient comes in, diagnosis, until treatment with the laser and post-op surgery or post-op SRP, laser-assisted periotherapy, laser bacterial reduction. So there's a lot that can be done in just the hygiene operatories as well as the preventative measure. And then we obviously have our flagship Waterlays products that are saving teeth and saving implants. And we have some incredible promotions here, at least for the US doctors that are on. It's called our BioLace Partnership Program. I'm not sure if everybody can see. It says I'm sharing my screen. I'm not sure if everybody can see it or not, but
I can see it.
Okay. So you can kind of see the evolution of our lasers here. We've come a long ways. The Waterlays I+ has been updated several times in the past few years with a more robust trunk fiber, also updated protocols. There's also a port in the back here for those that are overseas in Europe that can purchase the extraoral fractional handpiece. So they're actually doing skin resurfacing over there in Europe, scar removals, and I know that's something we're working on with the FDA here to get approval as well in the US. So we should have that very shortly. And then we have the new Waterlays Express, which just launched a few years ago. That is 4 watts. The difference between these two is this is a 10-watt laser. This is 4 watts. So if you're a restorative dentist, this one is going to cut teeth faster and remove those thicker Emax and zirconia crowns faster than this one. But let's say you're a periodontist and or oral surgeon, and that's what you're looking to incorporate this laser for saving implants and saving teeth. This is a perfect unit for doing that, and it'll cut bone and soft tissue beautifully as well. So we have 2 great options now at different price points for doctors to integrate the all tissue technology into their practice. So we're very excited. We continue to innovate. You saw those side firing tips for the implant surface that just came out a year or 2 now, and we have the radial firing tips for the peri-implantitis and the periodontitis as well. And then I know we didn't, we focused on that for this lecture, but We also have radial firing tips for endo. So that has been very, very popular this year among endodontists, and to help disinfect the root canals. And that is basically doing the same thing, but cleaning and disinfecting, getting into all these lateral fins, and just doing a phenomenal job of cleaning and shaping and disinfecting root canals with much less post-operative pain than traditional modalities, these endodontists are saying. So we're very excited about the momentum in the endo world as well. As we're here talking about saving implants and saving teeth, just wanted to mention the endo aspects of it as well.
Great. Yes, this all sounds very exciting and interesting. You guys, I know you also came up with a new diet as well. I'm aware of, but you have your information available for people to contact you.
Yes,
I'll
I'll leave it on this screen for a minute. So my email is up there and my cell phone as well. So feel free to email me, even if you're overseas, that's fine. And you're also more than welcome to go to biolaze.com. And from there, you'll be able to find our products. And you can always request more information from our website as well. And somebody will get back to you internationally.
Perfect. And look, I also know you guys have a phenomenal service program. So you guys, doctors are able to purchase service programs where you guys completely cover all the costs, if any needed, in all your units, right?
Absolutely, yeah. We take pride and take care of our doctors and our offices that incorporate this technology, and we want you to be successful with it. And one thing I will add, for the U.S. doctors, we have done something really, really important here during this new era we're in, where instead of having to fly somewhere over the country and go to a course, we're actually going to bring the training to you. So if you're worried about traveling, if you incorporate the Waterlaze into your practice, at least on the United States side, we are going to fly a trainer to your office. That's normally an additional $10,000 value that we're not increasing the price point on our lasers due to the current environment that we're in. So that's a huge, huge value. And
That's
we're
amazing.
also doing rebates right now as well when you incorporate this technology to put some cash tax-free into your hands. So
That's fantastic. That's really exciting. So,
absolutely. Thank you very much for having me on.
no, thanks for coming with us here. We're very excited to have you guys. BioLace, obviously, I appreciate you guys. Thank you.
Thank you, Dr. Kayvon. Have a great rest of your day.
Thank you. The same.
Hi, everybody. Thank you for joining today. I am Dr. Boros. I will be speaking with you about HPV-related disease of the oral cavity and oral pharynx. I am an oral pathologist. I practice in Los Angeles, and I also have an oral medicine practice in Santa Monica. I am faculty at USC as well, and I'm very happy to be here today. So thank you so much for having me. So we're going to get started. So HPV, human papillomavirus, it is basically an epidemic right now. And so it's the most common sexually transmitted disease. A lot of us will be exposed to this virus most often as a teen or a young adult when we first become sexually active. But thankfully, 98% of people that are infected will undergo spontaneous resolution in about 2 years. HPV is the main etiologic factor in more than 35,000 new cases of cancer per year. So a virus is responsible for the etiology of several different types of cancer. And the majority of these now are actually going to be oropharyngeal cancer. So a short form that is OPSCC. If you are probably familiar with HPV being the etiologic factor in cervical cancer, but as of 2020, it is more common to be, or the numbers for oropharyngeal squamous cell carcinoma have surpassed those for cervical cancer in relation to HPV etiology, which is pretty significant. So what is HPV? It's a DNA virus, and there's many, many different subtypes of HPV. Some of them are low risk or non-oncogenic, and others are high risk or oncogenic, and those are the ones that we worry about. So I'm just going to review a couple common HPV-related conditions in the oral cavity that you've probably come across already. So something like this, which, you know, you can have a strong suspicion clinically that this is something like a papilloma with those large, long papillary fronds. This is a location where you would commonly find this kind of lesion. And so that is an HPV-related lesion. This is a similar appearing lesion, but just a little bit more verrucous or cauliflower-like, not so much papillary. Both of these are examples of squamous papilloma. They're caused by HPV, but they're low risk, specifically types 6 and 11 most commonly. They can be pedunculated, meaning they have a narrow base, papillomatous, usually asymptomatic, found on routine exam. And these are the most common sites: the soft palate, the tongue, and the gingiva. We do recommend excision for confirmation with biopsy, so microscopic examination, because there are some instances where you can have early papillary squamous cell carcinoma mimicking a squamous papilloma. Once you remove these lesions, the recurrence is relatively low. You do want to include a little bit of the base of the lesion. You don't want to just transect it at the level of the mucosa, because you will leave a little bit of that root of the lesion behind, and that's when they may recur. Here's another example of an HPV-related lesion, also a low-risk subtype. These are more commonly seen in the anogenital area, but this is an example of a condyloma. They can be seen in the oral pharynx or in the oral cavity, a little bit larger, a little bit more cauliflower-like appearance as well. Here's one on the lingual frenum. And these again are biopsy for confirmation of diagnosis, because they can also mimic early papillary type squamous cell lesions. And so these are caused by several different low risk as well HPV subtypes. They are considered sexually transmitted, unlike a papilloma, which is not. Papilloma is more akin to like a verruca vulgaris of the skin. And clinically, like I said, we see them in the anogenital region, but also in the oral cavity and sometimes even in the larynx. Oral lesions most commonly will be seen on the labial and buccal mucosa, the palate, and the lingual frenum, like we saw here. So those are two, more common lesions that are caused by low-risk subtype HPV. There are other conditions such as Hex disease that is caused by low-risk HPV. But just because of time, I wasn't going to include all the different subtypes. So when we see something like this, this is when we start to get really worried. So here we have a photograph of the oropharynx in the relatively young male. And we see this large granular erythematous type lesion. And so this is already, just looking at it, hopefully all of you will be concerned. This patient has no recent history of upper respiratory tract infection or anything. This is completely asymptomatic, but this is an example of a biopsy-proven HPV oropharyngeal squamous cell carcinoma, and this is typically what it's going to look like. So I'm just going to talk a little bit about oral cavity and oropharyngeal squamous cell carcinoma now. So notice just in my topic for this slide, I've kind of separated out oral cavity and oropharyngeal squamous cell, and I did that on purpose. Even though all the data is still combined, we're starting to learn that these conditions are actually, even though they're both squamous cell carcinomas, they're actually pretty distinct diseases. So I think in the future, we'll probably be stratifying this data, and it'll be more specific to either oral cavity or oropharyngeal locations. So just combining all the data, approximately 53,000 cases in the US per year, almost 11,000 deaths, males more commonly affected than females by a 2-to-1 ratio, 5-year survival is 65%. It's the 8th most common cancer in men, so it is up there in the top 10. We know that oropharyngeal squamous cell carcinoma is most commonly caused by HPV. So up to 80%, so between 70 and 80% of cases are HPV related. And when I talk about the oropharynx, just want to make sure that we're understanding that that means the back of the throat. So the posterior pharyngeal wall, palatine tonsils, the base of tongue, that area. The more anterior you go, the less likely, if you encounter a squamous cell carcinoma, that it would be HPV related. And so it's established that only about 2 to 5% of cases are HPV related in the oral cavity. So the general rule is the more posterior you go, the more likely a squamous cell carcinoma will be HPV related. So, we all learned about high-risk sites for oral cancers. They remain the same. We just know that, the sites that are specific to more of the back of the throat area are going to be HPV related, just statistically speaking. So overall, just going to go over a little bit of how we, discovered how HPV was an etiologic factor in oropharyngeal cancer. So the overall incidence of HPV negative oropharyngeal cancer in this study here that I'm quoting, they found a decrease by 50% between these specific years, which correlates really nicely with the decline in the habit of smoking. But at the same time, they found that HPV positive oropharyngeal cancers increased a whopping 225% during the same period. So you kind of have, trend lines going in opposite directions. So oropharyngeal cancer, and this last point here I already covered, it has actually become more prevalent than cervical cancer, both HPV related, and that happened this year. So here we see a chart from that same study, and we're just seeing the dramatic increase in oropharyngeal HPV cases, whereas the oral cavity cases are remaining relatively steady, maybe declining a little bit. So, just in general, we can think of non-HPV related or traditional squamous cell carcinoma or head and neck squamous cell carcinoma of remaining stable related to smoking and drinking, but we know now several studies, numerous studies have shown that there is a dramatic increase in oropharyngeal HPV related squamous cell carcinomas in males, usually younger than 40. And so here are some typical examples of some photographs of some cases that we've biopsy proven squamous cell carcinoma here, an ulceration, again, not going to be painful, and this is a very similar looking lesion to one that I showed earlier, kind of a red granular appearing lesion of the oropharynx. And so clinically, this can translate to kind of two at-risk populations. So we have the HPV negative, HPV negative, smoking, drinking, classic risk factors, usually older age, usually males, and the classic high-risk sites. So lateral borders of the tongue, the ventral tongue, floor of mouth, those areas. And then we also have this other group of at-risk patient now that it's good to be aware of. Younger patients, we diagnose these squamous cells in people as young as 20 years old. 20 to 44 years is the most common range. White males, usually non-smokers and non-drinkers, and this more in the back of the throat, so the oral pharynx. So here are just, again, the same photographs here. So non-smoking, non-drinking HPV related here in the oral pharynx, and typical smoking, drinking, older male related squamous cell carcinoma in the oral cavity. So, HPV is, like I said, an epidemic. There are a lot of infections every year, but luckily that doesn't correlate, or it's not translated to the same level of cancers developing per year. And that's because just because you're infected, it doesn't mean that you're going to develop a cancer, because the HPV DNA genome has to integrate into our genome in order to become oncogenic. And that has to be the high-risk HPV DNA. So luckily, this occurs at a relatively low frequency. And so we believe that many of these infections are cleared and they're not integrated. But so I'm just going to clarify what I mean by integrated. So if we take a look at these pictograms that I have here, this is the HPV16 genome, and it has different proteins. So the L1, the E6, E7, and then this little thing right here is called a promoter. And so this is supposed to represent our DNA, the black line. And so if a specific part of that genome of the HPV gets integrated into our DNA in this specific way, it has its own promoter and it promotes these specific proteins. And these proteins, so this promoter can turn on translation of these proteins whenever it wants. If that happens, then you get increase in these proteins. And we know that these proteins, stop normal apoptotic the normal apoptotic process. We know that it's E7 plays a role in increased proliferation and immortalization of cells, and all of these things together cause genomic instability and mutations, and ultimately over time, and not something that happens over a year or two. It usually takes several years to decades for this to happen. These cells would transform into malignant cells. So that's, kind of an overview. A lot of this is extrapolated from the cervical cancer data. So we do know that there are specific biologic profiles of differences between HPV positive and HPV negative tumors. So HPV positive tumors have this specific viral oncoproteins that can be turned on and then over time transform epithelial cells. We think that it has significant overlap with cervical cancers in the way that HPV drives cervical cancers, but there is some new data to suggest that there might be slight differences between those two cancers, even though they're both caused by the same type of virus in the same subtype of virus. And so compare that to HPV negative tumors. HPV negative tumors have a lot more chromosomal mutations. They don't follow a nice kind of pathway. They don't have a unique molecular profile like we see in the positive tumors. And so that's really interesting because that translates to different clinical behavior. So as far as HPV-associated oropharyngeal cancer, how does this develop? How is it transmitted? So it actually is considered to be a sexually transmitted infection, HPV. And so there is data at our most recent AAOMP meeting. One of the presenters there said that there is an increased risk of even so if a female has or has a history of a cervical cancer, the husband or the partner is at increased risk for developing an oropharyngeal squamous cell carcinoma. So that's very, very interesting. And this study, obviously has a lot more findings, but just because of time constraints, I just wanted to point out that oral genital contact was strongly associated with development of oropharyngeal cancer, as shown in this New England Journal of Medicine paper, which is one of the kind of seminal papers of oropharyngeal and HPV, showing HPV being an etiologic factor in oropharyngeal cancer. So here's another example of a photograph of an HPV-related squamous cell. you can see that it kind of looks similar to that condyloma that I showed you at the very beginning, which is why, we do encourage biopsies of all lesions with submission for microscopic examination, because you don't really know unless you're seeing it under the microscope. And this cancer is actually probably not just this lesion, it's probably spread all through, this area. It's kind of hard to see the exact extent of the lesion. So that brings up a question of like, how do we detect these lesions earlier? Obviously, the earlier we detect these lesions, the the better the outcome for the patient. And so with oral cancer, we know that there is red lesion precursors and white lesion precursors, so leukoplakias or erythroplakias. And so we looked for those. And here's a great example of a leukoplakia on the gingiva. Remember, leukoplakia means white patch. It's not a microscopic diagnosis. It's a clinical diagnosis that just means white patch. The WHO defines it as a white patch that cannot be rubbed off and cannot be diagnosed clinically as any other disease. And then we have a differential diagnosis, meaning, an educated clinical guess, a list of microscopic diagnoses that we think this might represent. So my go-to differential diagnosis for leukoplakia is hyperkeratosis, meaning usually trauma-induced, akin to a callus on the skin, dysplasia, which is precancer, or cancer, squamous cell carcinoma. This happened to be a precancer of the gingiva, and same with this, precancer of the gingiva. So we look for those when we're screening, doing our oral cancer screening exams, and we biopsy them if they don't go away within 2 weeks. But for the HPV positive oropharyngeal squamous cell carcinomas, the early lesions are extremely difficult to detect because they tend to start deep within either the tonsils or the pharynx, where we can't visualize that area very well. And so no study to date has actually described a precursor lesion to oropharyngeal squamous cell carcinoma, but I would imagine that it would look similar to what we see in the oral cavity. So just wanted to talk a little bit about prognosis. This is for, again, combining the data for oral and oropharyngeal squamous cell carcinoma. If we look at the 5-year survival rate, so how many patients are alive at 5 years, we combine all stages in this column: local stages, regional stage, and distant meaning metastasis, regional meaning lymph node spread, local meaning primary site. So if we compare, say, melanoma to oral and oropharyngeal cancer, we see that the overall 5-year survival rate of melanoma is 91%, which is actually really good. And that, reflects the local stage of disease. So that tells me, just by looking at these numbers, that dermatologists and patients are, doing a good job at screening, right? So dermatologists are taking biopsies and are able to contain the disease and remove the disease and cure the patient when it's usually at the local stage. When we look at our numbers for oral and oropharyngeal cancer, we can't say the same thing. So we have 65% overall 5-year survival, and that reflects more the regional stage. So that tells me that when we're finding these lesions, they're already spread to the lymph nodes. And so that has a direct correlation with the patient's prognosis. So what we can really control as clinicians is trying to screen these patients, trying to find these lesions early, and trying to help our patients with survival. That's the only way that we're going to increase that overall 5-year survival number. So that's kind of, what we're aiming to do. Interestingly, if we compare the prognosis between HPV positive and HPV negative squamous cell carcinomas, they're quite different, and many different studies now have shown that. So it's actually, when we look at HPV positive versus negative tumors, consistently we see that HPV positive tumors have a better outcome. So that's a little bit of good news. Even though we're seeing a lot more of these cancers, the outcome is better compared to the conventional or traditional squamous cell carcinoma of the oral cavity. And that's believed to be partially because of the way these cancers developed, like I was just speaking to you about, the specific molecular profiles. Tends to be a little bit less aggressive type of cancer, as well as the fact that these cancers are more susceptible to radiation therapy. So that's also a very good thing. So those two reasons combined is why we think that HPV positive tumors have a better outcome than HPV negative tumors. With that said, if the patient has a history of smoking or drinking, that negates the better prognosis, even if it is HPV related. So it is well established that HPV positive tumors have a better prognosis than HPV negative tumors. Holds true after you adjust for favorable prognostic factors like young age in these patients or less comorbidities. HPV, and like I said, that's because we believe that these tumors harbor fewer genetic alterations. They're more sensitive to radiation. And like I said, smoking negates that better prognosis. So we do see an improved overall disease-free survival regardless of treatment. So that we ask the question now, can we give these patients less aggressive therapy, less aggressive radiation therapy? And so as far as I know, that hasn't been established yet, but there are clinical trials ongoing to see if that's a possibility to reduce the morbidity of this type of treatment in these patients. There's also a lower risk of second primary squamous cell carcinoma in the upper aerodigestive tract compared to traditional squamous cell carcinoma. So if you have a squamous cell carcinoma that's related to smoking and drinking, there's this concept of field cancerization where the whole area has been exposed to those toxins. And so you are at increased risk for developing a second primary if that's the etiology of your cancer. Whereas with HPV positive, not so much the case, but we do see a higher rate of a second primary squamous cell carcinoma in these patients in the anogenital regions. So they would need to be screened a little bit, increased frequency there. As far as prevention, there are several different vaccinations. These are they're on viral-like particles, so you're not going to have any type of live virus injected into your body. It's just devoid of any kind of genomic material, so you're not going to get infected with HPV from the vaccine. It prevents that step of integration into the genome and thus persistent infection, which decreases the development of mutations over time and ultimately of developing cancer. And we know that titers fall from a peak and they remain stable above a natural infection, but we don't know how long that lasts. So there are a couple unknown. There's 3 different vaccines that are available in the U.S. So there's Gardasil, which is quadrivalent, so it is effective against 4 different subtypes of HPV, 2 high risk, 2 low risk. There's Gardasil 9, which is 9-valent, which is recommended now for women and men. Initially, the vaccine was only approved for young women, and then young men were included. And now, I know clinicians that give the vaccine to middle-aged, even elderly populations, because there is actually a second peak of HPV infection. First is in younger patients, second is in older patients when they enter housing facilities, which is kind of interesting. Assisted living facilities. So, it might not be covered by insurance in the States, but it is something that I know a lot of physicians will give. So basically the protocol for prevention here is it's best if the vaccine is received before the patient's sexually active. First recommended for young females, but now it's given to young men, can be given up to the age of 45. But like I said, I know there are physicians that give this vaccine to any age group because of some of this additional data showing that second peak of HPV infection in older patients. There is some evidence to suggest that it also has therapeutic value. And so it is recommended for healthcare workers because of occupational risk. There are some unknowns that we don't, obviously know. The length of time before the titers fall below a threshold necessary to, give a new booster shot or prevent infection. So we don't know that data. And we don't know if cervical HPV vaccination timing, so the administration of the timing, is ideal for oropharyngeal HPV prevention. So we don't know if it's going to be effective in preventing oropharyngeal squamous cell. But I know there's one study out of England that was an in vitro study where they took tonsils out of, just routine tonsillectomies, and they grouped them into those that were vaccinated and those that weren't vaccinated. And they did find a decrease in HPV incidence in patients that were vaccinated. So that kind of is a first look at the fact that maybe it will be beneficial for preventing oropharyngeal squamous cell. So in conclusion, HPV infection is an epidemic. There's low risk and high risk HPV infections. Remember, low risk, most commonly papilloma, condyloma, but things like Hex disease are also associated with HPV infection. These are not going to be, they're not associated with development of cancer or oropharyngeal cancer, but the patients that have these, low risk strains might have high risk behavior. And so you might screen these patients a little bit more, especially with the condylomas. There's a high percentage of oropharyngeal squamous cell, HPV is associated with the vast majority of oropharyngeal squamous cells as the etiologic factor, so somewhere between 70 and 80%, and a very low number of oral cavity squamous cell carcinomas are HPV related, somewhere in the 2 to 5% range. So there have been many studies now that have shown an increase in the incidence and the proportion of HPV positive oropharyngeal squamous cell carcinomas. I talked a little bit about the incidence, but as far as the proportion is concerned, there are a couple studies that went back and looked at tissue from biopsies in like the 80s or 70s. They tested for HPV, and then they compared that to biopsy samples in the 90s, 2000, I think in the 2000s, and they found that there was a vast increase in the proportion of biopsies that were HPV positive in the oropharynx. So that's kind of interesting. And as far as prognosis, we know that HPV positive tumors have a better prognosis than HPV negative tumors. We think that's because they're more susceptible to radiation therapy, as well as the way that these cancers develop. It's a little bit more predictable and less genomically unstable. And then there are vaccines against HPV. We don't know yet if they're going to be effective against oropharyngeal squamous cell carcinoma, but they have done an excellent job in preventing cervical cancer. And so we're hoping that data translates to the oropharynx as well. So what can we do? Just talked a little bit also in there about prognosis and outcome for these patients. We have a 65% 5-year survival rate for oral cavity and oropharyngeal squamous cell carcinomas. So, I am always going to, promote every clinician, every dentist out there to perform comprehensive oral cancer screening exams. I see on every patient every time. I know that might not be something that we can all manage, just given time restraints, but at least every 6 months. If I see a lesion in the oral cavity and it's, a white lesion or a red lesion or any lesion, if it's not gone in 2 weeks, the standard of care is to biopsy that lesion. I'll even go so far as, knowing the increase in oropharyngeal cancers in young patient population, I'll look at the tonsils, and if I see a significant tonsillar asymmetry and the patient doesn't have a history of a recent upper respiratory tract infection, I'll refer them to ENT just to have ENT take a look, because that could be the start of something. It could be normal for them, but I'm not the expert in the throat, and so I want the expert to look at it, because the earlier we catch these cancers, the better the outcomes for the patient. So that is it for today. Hope everybody learned something. I think I finished a little bit early, but any questions? Okay, great. Thank you.
Good afternoon or good evening or even good morning to all of you out there, depending on where you are in the world. I'm Jay Resnick. I am an oral and maxillofacial surgeon and I practice in Los Angeles. Been there for about 25 years. Do a lot of teaching oral surgery and implants to general dentists. I've been very involved with Dentaltown and also started a website called onlineoralsurgery.com, which teaches general dentists and non-surgeons to do and become proficient in surgical procedures. So we're going to talk about today surgical complications that you need to know before you pick up that scalpel. And you know, the reason that we're talking about this is there are a lot of courses out there that dentists take that teach them how to do an implant, how to do a take out a tooth, etc. And the difficulty with that is that that really just makes you a, oh, my slides aren't advancing. Oh, let's try this again. There we go. That when you learn how to do something, you are merely a technician. But of course, those of us, we all went to dental school, we've all done some additional training, and we are doctors. And the difference between a technician and a doctor is that the doctor understands the why not, and the what if of everything they do. Why you should be doing this procedure, why you shouldn't, and what if something goes wrong? What do I do? And when it comes to surgery, you've got to understand those things before you even contemplate treating the patient. So, you know, it's not enough just to recognize a problem.
Whoa, that's not good.
Oh, I don't need this. I'm already late.
Somebody will come. Anybody out there?
Do you have a phone?
No. Sorry. Somebody! Hello? There are two people stuck on an escalator and we need help. Now, would somebody please do something? I don't believe this. You gotta be kidding me.
I'm gonna cry.
Well, there's not enough left to do, is it?
Hello? Hey, don't worry about it. I'll fix it in a second.
He said he can fix it. All right. All right. That's more like it.
So you don't have to just recognize a problem when you're in surgery. You have to know what to do about it. And that's one of the important things that we're going to talk about today. You have to know what to do for about complications before they develop, if they develop, and down the road. So don't forget this, that oral surgery is it's surgery, and you're cutting on a live person. You can make them bleed, you can hurt them. And so you have to completely understand everything that you do, that you're going to do before you do it. Of course, when I graduated medical school, we take the Hippocratic Oath, which unfortunately was not in ancient Greek, as you see on this page. Of course, it was in English. And one of the big tenets of the Hippocratic Oath is that we are taught to do no harm. Primum non nocere. Do no harm. And that's how you're taught. If you're going to do something that could potentially harm the patient, you either want to avoid doing that or really know what you're doing and know the risks and be able to handle them. So, you know, or a surgical residency is about 10,000 hours of patient contact, sometimes more. And so obviously, in any course you take over the weekend or any lecture you go to or attend, even if you do a mini residency, you're never going to have the body of knowledge that a surgeon would have. But what I want you to be able to do is to be able to, in everything you do that's surgical, including implants, is to be able to think like a surgeon. And what that means is you have to mentally visualize the procedure from the start to the finish all the way through. And that will allow you to anticipate what instruments you're going to need and have them ready, have them available. And if something occurs, know what instruments you might need to have handy and be able to get quickly to manage the problem. We measure once, cut twice. You do all the evaluation beforehand. You make sure everything is set. You've got everything you need, and then you go forward. The big thing is that you need to be able to anticipate complications. Everything we do in surgery can have intraoperative complications, and it can have postoperative complications. And if you're going to be doing the surgery, you need to understand those. You need to be able to anticipate them, know what you're going to do to manage them in surgery, and know what you're going to do with post-op complications. So you need to have a plan. Again, know how to avoid the complications of the procedure that you're doing, and be able to manage them without even having to think about it. It should be a reflex before you start that procedure. So the intraoperative complications we're going to talk about that you need to know about before are subcutaneous air emphysema, intraoperative bleeding, crown breaking off, retained root tip, damage to a tooth, damage to an adjacent tooth, which I'm not going to talk about because all of you in general practice know what to do for that already, and the possibility of oral antral communication. So this is an article I wrote in the Journal of the American Dental Association in April of 1990. That's hard to believe that's 30 years ago. But it was a patient that I saw when I was on call as a first-year resident who had had a tooth extracted, actually a third molar extracted by his dentist earlier in the day, and dental handpiece was used to section the tooth. And over the next few hours, he started noticing a little difficulty swallowing, increased fullness in his neck, and you can see on the upper right photograph where I outlined with a just ballpoint pen the extent of the redness and fullness in his neck. When he was beginning to have some trouble breathing, and so I admitted him for observation overnight, to which I got some criticism from my senior residents, which is why I wrote this article. So what is subcutaneous air emphysema? It's due to air being forced in the subcutaneous tissues in any part of the body, but of course we're talking about the head and neck, and it can either occur immediately while the procedure is being done, or it can be a delayed response. Any kind of treatment that we do that uses any kind of air-driven handpiece, whether it's endodontic, surgical hand, or a standard dental handpiece, air water syringe, anything that can force air into the tissues is a possible risk for subcutaneous air emphysema. Especially if there's a lot of inflammation in the tissue, it's much easier for the air to penetrate. One thing that's pathognomonic of air emphysema is when you touch the area on the patient of where it's swollen, the typical description of this is that it feels like Rice Krispies or Pop Rocks. So we call that Rice Krispies or Pop Rocks crepitance, which means crackling in the tissue. And on radiographs, it will show air in the tissues, both in CBCT and plain films. So the most important way to manage subcutaneous air emphysema is to not let it happen to begin with. You use a surgical handpiece for surgical procedures, and that means a handpiece that vents to the back. And this is a 45-degree angle handpiece that attaches to your regular dental unit, and the air vents to the back. This handpiece is made specifically for doing surgical procedures. rather than using a regular dental handpiece. Also, you want to avoid, if you're using an air-water syringe, use it very carefully, especially when there's inflamed tissue. Another type of handpiece, this is what I use in my office, is a straight surgical handpiece. This is an electric handpiece. No air comes out the front of the nose cone of the handpiece. And so this is important to prevent air emphysema. Now, about 10 years ago, I had done a CE class or CE course on Dentaltown about air emphysema. And there was a lot of discussion about it. And I remember specifically a pretty well-known periodontist had posted that, in his 15 years of practice, he had never seen a subcutaneous air emphysema, and he had never seen it in the periodontal literature. So it's really not that, and of course they use regular dental handpieces for all their osseous surgery. And so really it's not a concern. And so I said, well, you know what? I see it a few times a year coming into my practice from one of my referring dentists, and it does exist. It's just the periodontal literature has not written an article or written a case report of subcutaneous air emphysema, but it will happen. About 6 months later, I get a direct email from him saying, guess what? I was doing some osseous surgery with my regular dental handpiece, and patient developed while I was working a subcutaneous air emphysema. So this is not something that is theoretical. It's something that happens more often than we actually recognize. So what do you do when this occurs? How do you manage it? Well, first thing you need to do is to reassure the patient that that you know what this is, and it's something that most likely will resolve on its own in a few days. Moist heat over the area that's swollen is really helpful. I think it's prudent to give prophylactic antibiotics, something like penicillin, Keflex, clindamycin is fine. And if there is a report or complaint by the patient of difficulty swallowing or even difficulty breathing, especially when they lay back, I think this warrants admission to the hospital overnight for observation and possible airway management, because there are some rare cases where patient had to be intubated because they were unable to breathe before this resolved. But like I said, it does resolve on its own. If it's small, within a few days. If it's more extensive, it may take 2-3 weeks to completely go away. The next complication that you need to know about before you pick up the scalpel is about intraoperative bleeding. And bleeding can occur. Oops, I thought I put that on silent. Sorry. Bleeding can occur from any surgical site. There we go. From any surgical site, whether you are taking out a tooth, making an incision, or whatever you're doing in surgery. But generally, bleeding from surgical sites can be controlled by local measures. Basically, just putting pressure to control the bleeding. So the number one is gauze pressure. And you can see here, I have a 2x2 gauze that is folded or rolled into a rat tail. And so if I am doing surgery and all of a sudden there's bleeding from the socket or bleeding from the incision, I'm going to pack the surgical site immediately. And my staff knows exactly what to do. They are going to hand me this 2x2 gauze on the hemostat so that I can pack it into the site and put pressure to get the bleeding to slow down or completely stop. And you may have to do this multiple times before the bleeding actually slows down. Another thing that's handy are some agents that help hold the clot. One that we use most commonly is gel foam. It comes either in little squares like this, or it comes in a big sheet that you need to cut into little pieces and have them, sterilize them in the bottle so that they'll be sterile for use. Another agent or another material that's used to stop bleeding is Surgicel. So gelatin is actually an animal product from animal gelatin, like from cartilage. The Surgicel is absorbable oxycellulose. So this comes from plants. Now, gel foam is like a little sponge, and it tends to get a little kind of loses its shape, and the Surgicel is basically like a cloth. So what I like to do sometimes is to actually take the Surgicel and wrap it around the gel foam square and then pack that into the site. I think it gives you a little bit more bulk, a little more pressure as you're putting it in, and works quite effectively. Sometimes we have to use topical thrombin. Oh, and by the way, suturing. Some people erroneously think that if they have bleeding, that if they suture the site, the extraction socket, that's going to get the bleeding to stop. That's not correct. What gets the bleeding to stop is the pressure initially, followed by either packing the site with gel foam and or Surgicel, and then using the suture to hold that packing in place. The suture itself will not stop bleeding. Now, when I have a patient that's sent to me who has bleeding that doesn't seem to be able to be controlled with just pressure, one of the agents that we use is topical thrombin. And so this comes in a little powder. We reconstitute it with sterile saline and soak again, a 2x2 gauze with it and pack it into the site. And thrombin is sort of at the end of the clotting cascade and directly causes the clot to form, the fibrin released from the platelets, and for that clot to form. Another thing that can be used is a local anesthetic that has vasoconstrictor only if the bleeding is coming from the soft tissue. If it's coming from the socket, injecting local anesthetic into the socket or dribbling it in the socket is not going to do anything. If you have bleeding from within the bone, there's a product called bone wax, and it's basically just sterile beeswax, and it comes in a little packet, and you take off a little round little piece about the size of a BB. And if you have bleeding from the bone, you've got to slow down the bleeding first with gauze and pressure, and then pack the gel foam and smooth it in, kind of condense it in to slow down or stop the bleeding. And so this is something that as surgeons, we always have available in the office. Now, another thing that can be used if you have, let's say you've packed a site and you want to make sure that the packing doesn't come out, you've sutured, is to use cyanoacrylate tissue glue, basically crazy glue, but it's sterile and costs 10 times as much. So the brands out there are Dermabond, Histocryl, Periacryl, which we use in my office because it comes in a little pipette. You draw it out of put a little dish, draw out just what you need for that case, and then you apply it over the gel foam or whatever packing you're using. Another one is Isodent. With the Dermabond, which you see in this photo, which is what we used before Periacryl, is I'd actually take a syringe and stick it into the stopper and draw the cyanoacrylate tissue glue into the syringe, and then use that to basically dribble over the site to seal that gel foam in. Now, if those measures don't work and there's still bleeding, another thing you can use, and this is something, again, that most oral surgeons have in their office ready to go, is aminocaproic acid or tranexamic acid. And what I'll do if I have acute bleeding is, again, I'll soak a 2x2 gauze or a couple 2x2 gauzes with this and have the patient bite down on it with firm pressure, leave it in there for 5-10 minutes, and then we'll check again and see if the bleeding has slowed down. Now, if we anticipate bleeding, and the most common condition where this solution is used is for patients who have von Willebrand's disease, or they have a clotting factor deficiency, another clotting factor deficiency, is we have them rinse with essentially a mouthwash that we have compounded from one of our local pharmacies. Unfortunately, the one Hal's you see right here in San Diego closed. But if you want if you want to know another source, you can feel free to email me afterwards. So we have the patient, we take 10 cc's of it, we have the patient hold it in their mouth for about 2 minutes, about 30 minutes before surgery, and then every 2 hours after surgery, they do the same thing. They just hold it in their mouth. They don't swish it for about 6 to 10 doses. And so that is another good way in patients who you suspect they may bleed, that you can hopefully have a minimal risk of having significant bleeding. Patients who are on Coumadin, by the way, we rarely take off of Coumadin unless we're doing 4 or more extractions in the same area, in a contiguous area. Those patients, when you pack the Surgicel and gel foam, rarely have, very rarely have increased bleeding. Patients who are on some of the newer anticoagulants like Xarelto or those tend to have, you notice the blood will be a little thinner, they have a higher incidence of this happening. And so you want to have these patients, if you can, get the aminocaproic acid and have them rinse with it, 2 minutes before, 30 minutes before, 30 minutes before surgery, and then afterwards for about the next day. So what I learned in medical school is something that I'm going to share with you, is that all bleeding eventually stops. And so you can think about that. But generally, we want the bleeding to stop because we stopped it, not because the patient exsanguinated. And so these measures that I've shown you are ways to stop the bleeding intraoperatively. This is probably the most frightening intraoperative complication that I hear about for most non-surgeons who are doing surgery. So again, anticipate surgery, anticipate bleeding in surgery, anticipate all the things that can occur, and be ready if they occur. Now, what if you're trying to get a tooth out, a decayed tooth, and the crown breaks off? Well, then you're left with roots. And automatically that changes from being a non-surgical extraction to being a surgical extraction. And in order to do a surgical extraction, you need to have the right instruments to complete the job. And what I use for atraumatic extraction of roots are these instruments here called proximators. And what they do is they move down the periodontal ligament space, sever the PDL, and also apically push the root. And so the way these work is, here is a tooth that I'm planning to take out, and you can see how, as I'm doing the extraction, the crown breaks off. And so now, rather than, the crown's going to break off in a second. There we go. Now the crown shatters and comes off. So now we have a surgical extraction. So instead of playing with your elevator and forceps for the next half hour, then giving up, you use the right instrument that is going to, as atraumatically as possible, allow this tooth to come out. And so again, you're going to walk this instrument down the periodontal ligament space as much as you can, 360 degrees around the tooth. And as you do that, the tooth will become more mobile. And as you advance the instrument towards the apex of the tooth, you'll see that it'll become displaced, where you can just go in with a hemostat and very simply remove the tooth. Now, what if this happens with a maxillary molar? Again, if the crown breaks off, the first one you saw was a premolar. What if you have a maxillary molar where the crown breaks off and this tooth has 3 roots that go in different directions? It's really no different. You treat it like a surgical extraction. So what you do is you then section between the roots so you can take out each root individually by the same technique that I showed you before. And usually the mesiobuccal and the mesiodistal roots will come out using the proximator or similar instruments. And generally, you can grab the palatal root with a narrow forceps and rotate it, and that will allow it to come out fairly easily. So you have to take that single-rooted tooth, that multi-rooted tooth, and you have to turn it into 3 single-rooted teeth, or 3 single roots. And then you can remove them. So a little bit, and you can see sometimes it breaks, but you just be persistent, and you'll be able to get all 3 of those roots out all the way to the apex. Now, what about if just a little bit of the root breaks off, not the crown breaks off, but most of the tooth comes out, as it did here, and but a root tip is left behind. So, excuse me. So here is a case. Notice there's a little curve to the distal root, and this tooth is removed, and there remains that distal section of root when you take the tooth out. Well, you need to, again, convert this to a surgical extraction, which means making a small incision and laying a flap so that you can see what you're doing. Doing surgery blindly does not work. You've got to see what you're doing, or you're not going to be able to accomplish it. And so here we're going to use a root tip pick to get around the root and or get aside the root, between the root and the alveolar bone, and displace this tooth or luxate this tooth out of the socket. Now, a root, when it breaks, generally doesn't break straight across, it breaks obliquely. And so there's always a high side, as you can see in this illustration, of the fracture. So you want to engage the root tip pick in the high side of that fractured root and displace it towards the center of the socket. And so you can see here, we've gotten the root out. Oh, actually, no, the root's not out yet. Sorry, I'm not. The video's on a different screen. So what we're going to do then is we're going to create a small trough with a narrow burr like a 701 burr, and we're going to make some space. We're going to make a moat around that root so the root has some more room to come out. So usually when roots don't come out just with a root tip pick, it's because the root tip is fairly bulbous, or the curve goes in a direction opposite of where you want it to go. So here you can see the root, and now we can get our root tip pick in there now that we've made a little more space, and we very simply remove the root. And so if you're going to be doing extractions, you need to know that these complications can occur, and you've got to know what to do for them in surgery, rapidly and efficiently, rather than just doing the same thing over and over again with an elevator and forceps, and then eventually having to send the patient who's been beaten up for an hour to the oral surgeon, because we don't like that. Patient doesn't like that. It's not good for anybody. What are some other tricks for removing some root tips? Just showed you troughing around the root with a 701 burr. There are also specific root tip forceps, and this is called a Stieglitz. It comes in either a straight or excuse me, angled variety, such as this one. And you can use the Stieglitz to basically grab the tip of the root. So it gets grabs, it's much more of a strong grip than, say, using a small hemostat. And so the Stieglitz, as you can see how it's reinforced at the tip, and it comes to a very sharp point, is something that you need to have in your arsenal if you're going to be taking out teeth. Another trick that I learned in residency from one of my instructors was using endophile. You take a number 40, 50, 60 endophile, not too thin, not too thick, and you literally screw that endophile into the pulp chamber of the broken segment. And then a lot of times you can just pluck it out on its own, or sometimes you need to get a little more leverage. So you'll put a piece of gauze on the adjacent tooth, and with a needle holder, use that adjacent tooth to give you leverage to remove the root tip. It's really a nice little trick that I like to do. Now, another thing that can occur is what I'm going to show you next. Now, this is where it is critical that if you are going to be doing surgery, you need to understand the anatomy of where you're working. So this woman is a 53-year-old woman who was having pain in tooth number 1. Looks like a simple, straightforward extraction. Went to her dentist. Her dentist went to take out the tooth. The crown broke off the tooth, and he called me in a panic, saying that he thinks he pushed the root into the sinus. Actually, there it is. He thinks he pushed this root into the sinus because he sees some yellow stuff coming out of the socket. So I have him send the patient right over, and one of his assistants came with the patient. And since it sounds like he pushed the root into the sinus, we're going to go ahead and get a CBCT so we can see exactly where that root tip is, and already have that information before I go in to see the patient for the consultation. And when I saw the CBCT, well, you can look and see where that root tip is. It's right in the socket. So what was this yellow thing that was coming out in the extraction site? Again, knowing your anatomy and knowing the complications of working in that area, doing surgery in that area, are critical if you're going to be doing surgery in that area. So here's what he saw. And if you've never seen this before, this is the buccal fat pad. And the buccal fat pad was herniating through his an incision that he made, and pretty good volume of it was protruding into the mouth. As you can see, just hanging right there. So what is the buccal fat pad? It's a pad of fat that lies deep to the buccinator muscle. And when you lay a flap to expose a third molar, as you can see in both these illustrations, the only thing between your flap, and the buccal fat pad is the buccinator muscle, which can be very thin in this area. And so if you extend your reflection of the flap too far, or you don't make it in the right place, the buccal fat pad can extrude. So what do you do if this happens? Well, what we do is I will immediately take a hemostat and essentially just stuff it back in. Now, if you do that, when you take out the hemostat, release the hemostat, it's just going to herniate out again. So what you do is you repack it, and then you take, again, a 2x2 gauze, and you stuff it into the area so that you're pushing the buccal fat pad a little bit higher. Okay. Now you're not going to leave that gauze in permanently, obviously. When it looks like it's staying in place, then you can get some gel foam or Surgicel or a similar type of packing and replace the gauze with that, and then suture your incision closed. Now, what if you can't get all of the fat pad back in? Well, you can excise a little bit of it. So maybe half of what you saw in that previous photo, the original clinical photo, you can cut that out and it won't cause a major facial asymmetry. And just so you know, a common procedure that plastic surgeons do to reduce the fatty look of the face, the kind of a puffy look of the face or cherubic look of the face, is they purposely incise through the vestibule and expose the buccal fat pad, and they take out equal amounts of buccal fat pad from each side, and then put a little packing to hold it in place, and then suture it closed. And it makes the cheeks much more prominent. It reduces the puffiness in the cheeks, and is a fairly common aesthetic surgical procedure. What about when you're taking out a tooth and you actually do displace the root into the maxillary sinus? And you can see in this radiograph that was sent over with the patient from his dentist that there is a root tip in the maxillary sinus. And so what do you do about it? Well, the best thing to do is to try to get it out as soon as you can. Sometimes I'll open, if you see the opening where the tooth was pushed through, I'll open that a little bit wider and go in with my suction and see if I can get the tooth to come out at the tip of my suction, because as a general rule, the root tip always stays under the sinus membrane. It rarely penetrates it. But in this case, we're going to get a CBCT, because I want to see exactly where this root tip is located. And you can see that in a very short time between when the patient had this occur and then made it to my office the next day, you can see a significant amount of fluid in the maxillary sinus. And you can see exactly where that root tip is, and it's basically under the sinus membrane. So it's between the sinus membrane and the floor of the sinus. So how do we get this out? Well, what we do is we basically do the same thing as if we're doing an open sinus lift. We make a Caldwell-Luck incision. I use the piezo surgery unit, and I use that to gently atraumatically lift the membrane off of the bone and to raise a flap. And now I'm going to go in with my suction, and you'll notice the suction, I don't know if you can see it, has a little vent hole at the tip, and this is made specifically for sinus surgery so that you can suction without it grabbing the root tip. And when I do that and move it around, I could actually visualize the root tip and then go in with my suction and just remove it at the tip of the suction, as you see right here. So that's how we do it. Takes about 10 minutes, 15 minutes to do, and patients generally do very well after that. Now that we're in the situation, of course, the patient has a pretty significant oral antral communication that was created by the tooth being pushed into the sinus. And the patient also, as you can see on the bottom, had an implant, wanted another implant up above. So simultaneous with removing that root tip, I also did an open sinus lift to build up the bone volume in the sinus, as well as doing a ridge preservation graft into the extraction socket. And so you can see here, this is 4 months later, how well this graft has healed. We went on to, very shortly after that, place the implant, and this is about a year and a half later after it's been restored, still very healthy in good solid bone, as you can see. Let's talk about third molars. So if you're going to be removing third molars, you've got to be able to look at a panoramic radiograph or a CBCT and know what you're looking at, know where the tooth is, know how it's positioned, how it's related to other structures. So this is a 17-year-old female who had asymptomatic third molars. She came to my practice, and because of the way that the appearance of the lower thirds on the panoramic, where you can actually see the occlusal of the tooth, that of course you're going to suspect that the tooth is rotated either to the buccal or lingual. So we're going to go ahead and a cone beam CT, which will allow us then to see exactly where this tooth is rotated, and you can see it's pointing to the lingual. And so when we do the surgery, we're aware of this so that when we go in, we know that we're going to see essentially the root end of this developing tooth and not the crown, and do our surgery appropriately. So you can see how these are angled to the lingual, and of course, you want to make sure that you get the tooth out to the buccal and it doesn't go anywhere else. Like in this case, this is a dentist who saw a patient. He had two lower third molars, a little pericoronitis. So he decided that he was going to take out the two lower third molars for this patient. Well, he got out tooth number 32 with no problem. And then when he went to take out number 17, it disappeared. And he again called me in a panic. And this is a dentist that doesn't normally refer to me. He's like an hour and a half away, and he sent the patient to my office with one of his dental assistants so I could help him out. So what happened? Well, there you can see the Panorec that he took post-operatively before the patient was sent, that this tooth appears to be along the ramus of the mandible. And you would guess, since he didn't see it come out buccally, that it went to the lingual. So again, we're going to get a CBCT. We're going to look at a 3D view to analyze where this tooth is. And as you can see, it's in a pretty precarious place. It's right next to the, on the medial side of the mandible, next to the lingula, where the mandibular nerve, artery, and vein pass into the mandible. So the way you manage this is by doing nothing at first. You place the patient on antibiotics and you let the wound heal. You wait about a month, and then you bring the patient back to do surgery. What happens during that month is that this tooth will become encapsulated with a fibrous capsule and will adhere to the adjacent tissue. If you were to go in immediately to try to get that crown out, every time you grabbed it, you risk the chance of pushing it deeper and deeper. So by giving it a month to kind of mature, it makes it easier and safer to remove that root tip. What about nerve injury? That's the number one cause, number one etiology of lawsuits against dentists. And of course, the nerves that we're most concerned about are the inferior alveolar nerve and the lingual nerve. And the way that you can avoid this is by preventing it. And so you want to know the relationship of the mandibular nerve to the tooth. So on this radiograph, if you look at a radiograph in this drawing that I'm going to show you here, you see that the path of the inferior alveolar nerve is not disturbed at all by the shadow or by the tooth presence. When you see a canal like this, where the cortical outline of the canal disappears, then you know that the nerve is actually in contact with the root. And if you see the loss of continuity, not only of the cortex, but also of the nerve canal, then you know that this root is perforating, the nerve is perforating through the root. As in this case, and I know we're running out of time, you can see that the distal root, you can see the outline of the mandibular canal, but on the mesial root, it completely disappears. So as you can see in this surgical photograph, the distal root came out just fine, but the mesial root did not come out fine and had the mandibular nerve passing right through the middle of it. So the tooth needed to be split in order to get the root out. And you can see the distal root on the upper left, and on the lower right, you can see the grooving in the mesial roots where the nerve was passing. So I guess I only have 40 minutes. And, oh, I'm good? Oh, I can keep going. Oh, good. Okay. You'll let me know when I can stop. All right. So let's move on to something else. So this is another case. Whenever I see the mandibular nerve close on a panoramic, I'll go ahead and get a cone beam CT because I want to prevent problems. And you can see here on the left how the mandibular nerve seems to be passing passing by the number 32, and on the left side, the nerve actually goes through the roots. So really important, if in this day and age, the standard of care, if the root is close to the mandibular nerve, the root of the third molar or any tooth, you want to make sure you get a preoperative cone beam CT. If there's nerve injury, then what do you do? Well, luckily, it doesn't occur all that often. About 0.5% of patients after third molar surgery will have a transient numbness. Permanent numbness, on the other hand, is also very rare and occurs about 1 out of 20 to 25,000. The prognosis depends on how bad the injury is. So a neuropraxia, which is just sort of a very minimal injury to the nerve, a pressure injury or pulling of the nerve, generally has the best prognosis. An axonotomesis, where there has been more severe damage, like a crushing injury to the nerve, takes longer to regenerate. And a neurotomesis is where the nerve is actually transected. And of course, these have the worst prognosis and many times need to be repaired. So when a patient says they have a numb lip, you want to ask them whether they have a paresthesia, an anesthesia, or a dysesthesia. So do they have partial numbness? Do they have complete numbness? Or do they have some numbness with pain when they touch their lip? And again, a paresthesia has the best prognosis for recovery without doing anything. If they have a full anesthesia or a dysesthesia, then those are the patients that probably need to be referred ASAP for evaluation for nerve repair. When I have a patient that comes back at their 1-week follow-up, or even if they call me, the night of, or when I call them the night of surgery, they say they still feel numb, I will start them immediately on some corticosteroids like a Medrol dose pack. If they have pain, if they have some dysesthesia, I will put them on Neurontin, gabapentin, and start at 150 milligrams once a day, then they go to 300 once a day, all the way up to 300 milligrams or even more 3 times a day until the pain goes away, and then try to wean them off of it after a couple months. So, is surgery necessary? When should you immediately send the patient for evaluation? Well, obviously, a couple weeks anesthesia, paresthesia is not resolving. But if you observe a transection of the nerve in surgery and they have total anesthesia, then you want to send the patient to someone who can evaluate the patient for nerve repair right away. So the best treatment in this case is to refer. What's another complication of removing a tooth? Well, it's mandible fracture. Who has the highest risk of mandible fracture? Well, you need to know this. If the patient is a male, if he's over 35 years old, if it's a deep impaction, if there was infection present before surgery and they have impaired healing potential, they're on chronic steroids, they're diabetic, these are the people you need to look out for. Generally, this is not going to occur. A fracture doesn't occur at surgery, but it occurs in the 1 to 3 weeks after surgery. And if it happens, unless you are very competent at treating mandible fractures, you want to refer the patient right away. When the patient comes in and they say their bite changed, all of a sudden they have numbness a week or 2 after the surgery, and they have increased pain. The way we treat these mandible fractures depends on the displacement of the fracture. If it's not displaced or displaced minimally, we can do a closed reduction, which is wiring the patient's teeth together. If it's a significant displacement of the fragments, then we have to do an open reduction where we actually go in surgically, line the bone segments up, and put a plate to hold them in place. So again, change in occlusion, pain when clenching, they have an increase of bleeding or swelling, and mandibular nerve symptoms. Those are all indications of a fracture. And again, it can happen, up to even a month after the tooth is taken out. So here's a case where a woman was in France, actually a French woman, had tooth number 17 removed by her dentist. She said that it was a difficult extraction and everything was fine until 1 week later, she started getting some pain and swelling in the area of the extraction, number 17. She happened to be visiting a relative in my local area. She saw a local general dentist who took a periapical radiograph looking to see if maybe there was a bone sequestrum or something else going on. And he saw a little fracture line there. So he sent the patient to me for treatment. And you can see in the panoramic, especially when I blow it up, there's a fracture line going all the way from the top down to the inferior border of the mandible. So this was treated by a closed reduction because there was no displacement of the fracture. And here it is now 7 weeks post-treatment. What if you get an oral antral communication? Well, I already showed you if we have one at surgery, what to do. So, the treatment is basically the same, a Caldwell-Luck osteotomy and using a bone graft and membranes to close and seal the hole. In the old days, they used to use gold foil. That sort of is a thing of the past. Most people think that the upper third molars are the most likely teeth to end up or have an oral antral fistula after the tooth is removed. But it's actually the first molar. Upper first molar is the most common. So the best way, again, to treat this is to avoid it to begin with. So if the teeth are, or if the roots are divergent, then it's probably not a bad idea to go ahead and section off the crown and then section the roots individually so you can take them out without having to put too much force on the tooth and risk creating a perforation into the maxillary sinus. Again, prevention is always a good thing to do. And so if I see that the third molars are close to the sinus, I'll go ahead and get a cone beam CT. And you can see here that in these impactions of the upper third molars, the bone between the socket and the sinus is like an eggshell. So in a case like this, you anticipate an oral antral communication. And the way we generally treat this when we see it in surgery, if it's small, is we'll do careful curettage of the site, of the socket. place some gel foam or a collar plug in the site, release a little tissue, and do a primary closure. If it's another tooth that we're going to replace with an implant, of course, we're going to do a bone graft, and we're going to add an extra barrier membrane at the floor of the sinus. Small perforations will generally close by themselves. We always give our patients sinus instructions, which I'll show you in a second. And generally, it will close on its own within a few weeks. If it doesn't, then you want to refer this to someone for management. Now, here's a case where that was sent to me that was sort of a mystery to the dentist. And again, you know, knowing what you're looking at and knowing your anatomy is very important. So this patient presented to his dentist, and the dentist looked up in the vestibule and saw what he said. It says, evaluate on the referral slip, evaluate buccal number 3, open flap, had prior endo lesion, but has not healed for 2 years. Please advise on the treatment necessary, if any. Well, of course this needs to be treated, because of course, if you have experience, you're going to know what's going on. If the endo lesion didn't heal, you now have a fistula from the infection at the apex of the tooth into the oral cavity, following the path of least resistance. So in a case like this, again, we're going to anticipate an oral antral communication. You can't help it in this case. And so we're going to do what we did in the previous case where we remove the root tip from the sinus, is we're going to take the tooth out, we're going to carefully curette the site, and we're going to do ridge preservation along with an indirect sinus lift. This is at 6 weeks post-op, right before I took out the membrane. And then this is now 4 months later where it's completely healed over, and we're going to go ahead and place an implant. So what do you do if there's a sinus exposure? Because oral bacteria don't belong in the sinus, you want to put the patient on a course of antibiotics. And generally, it's a longer course when you're dealing with the sinus because it doesn't have great vascularity. So about 10 to 14 days. Amoxicillin or something similar if the patient is allergic is a good choice. And generally a decongestant, some type of antihistamine, or possibly something like Sudafed or some of the adrenergic agonists that dilate the nasal mucosa, but generally best to stay away from those. So sinus mucosa or sinus instructions, if there is an entry into the sinus, this is what we give to the patient. Is basically avoid, blowing your nose too hard. If you sneeze, don't close your mouth so it comes out your mouth, and then no straws for at least a couple of weeks. And if there's a problem, come back and see us. Take some Sudafed if it's indicated, if the patient doesn't have cardiac issues, and the Afrin or neosynephrine spray, which again has to be used very cautiously, and of course the antibiotics. Now, post-op complications, bleeding post-op is pretty much handled just like intraoperative. You pack the site until it slows down and stops. Another one is infection, of course, which is fairly common, about maybe 3 to 4% of the time. Sinusitis, dry socket, sequestration of bone from the socket, which will create an infection, lingual mandibular sequestration, late fracture, and late paresthesia. So post-op infection you usually don't see until at least the 3rd or 4th day after surgery, and the patient, rather than feeling better after the 3rd day, has increased pain and swelling. There's inflammation around the incision, sometimes some erythema on their skin, and the patient will complain of a foul or sour taste. So you're going to treat this with the standard antibiotics, amoxicillin, Keflex, clindamycin. It's usually due to food debris or bone sequestration in the socket. So it's probably a good idea to numb the patient up and go in and thoroughly debride the socket and get the food or a small fragment of bone out. If it involves the soft tissues, there's significant swelling, we may need to place a drain into the site so it doesn't close over, or even do an incision and drainage into the buccal vestibule. And this is a case illustrating a post-op infection in a 16-year-old She had impacted third molars. She had pain and swelling now 2 weeks after surgery. And you can see here the little fragments of bone that have come loose in the socket. And on the view on the right, you'll notice some pockets of air. And this is pathognomonic of an infection because the bacteria in an infection will release air and create air pockets within the surgical site. So whenever you see air pockets and fluid in a surgical site, that tells you that there's an infection. So we treat this basically just by debriding the site out and thoroughly cure it out. And once the patient's numb, and get all that stuff out of there. Dry socket is probably, we see about 10% of the time, especially with lower third molars, less frequently with other teeth, and rarely with maxillary teeth. This is known as localized alveolar osteitis. It's not an infection, but it's loss of the blood clot. And what causes it, nobody really knows. They think it has something to do with your body reacting against bacteria that are in the clot that got in through your oral cavity, but nobody's really sure. And I guess there's not enough money in trying to figure out what causes a dry socket that anybody, there's not a lot of great research on the etiology. So treatment, standard treatment is with dry socket paste. As you see here, what we do is we put the dry socket paste in a syringe, and for most of them, the main ingredient is eugenol or oil of clove. You can also saturate clove oil with a gauze packing, but the thing to remember, if you place gauze packing, you need to have the patient back in a day to take it out and change it. You don't want that packing to be in there too long. The patient can develop an infection from the presence of the packing, and they can be pretty nasty. So again, clove oil, or if the patient can't find clove oil at the pharmacy, this Red Cross toothache kit in the bottle is clove oil. And again, a dry socket should not last more than a couple days. If it does, you've got to look for other causes for the patient's symptoms, like possibly infection. So just remember, when things don't seem right, there's a good chance that something's wrong. So always have a plan. Know how to avoid the most common complications of the procedure you're doing. Know how to manage them without having to think about it. And never look at a surgical case, a surgical procedure, and say, I think I can do it. You have to say that I know I can do it. If you can't say I know I can do it, you don't do it. So we're done. Thank you for your attention. We've reached the finish line. If you have any questions, you can reach me at j@onlineoralsurgery.com. And thank you, and I hope you enjoy the rest of this symposium.
So good evening to everybody. Sorry about the delay. We'll get right into it. I'm Dr. Monraj Bath. It's exciting to be here. Thank you to the powers that be. As far as the AAOS, the Global Summit, I'm excited to discuss with you about my GPS and novel uses of these new guidance systems. The goal is basically going to be to try and give everybody an understanding of new technologies that are available, how they improve patient outcomes, and apply these new surgical methods and procedures, ultimately to improve surgical accuracy and improve and maintain blood supply to surgical sites in the methods that I've used as of late. So this is me. I am a apprentice falconer, something a little bit different. So I like to kind of keep my hands dabbling in different things. So this is me. I'm practice in Pickerington, Bexley, and Westerville, suburbs of Columbus, Ohio, and the Ohio Center there. And we are going to discuss GPS, or what I call guided positional surgery. The idea here is that we have to, sorry about that. We have to believe in better 3D implant placement, and the results are based off of a three-dimensional person. So we should be planning our surgeries in 3 dimensions. Objectively, we just basically want to combine these 3D technologies of CBCTs and these guidance systems, making a workflow and integration to not only utilize for all-on-4s, et cetera, but this technology can also now integrate intraoral scanning and having a completely digital workflow. When I made this lecture 2 years ago, some things have been updated and changed. So I'm excited to talk about this and update you as we go. So a couple disclosures. I do have a history with Elman and Megagen in the past, and that's how I got involved with the dynamic navigation. I do have a small investment in navigation, or in the navigation company of XNav Technologies. Evolved this basically through a spring of 2016. I was at a meeting, and next door to Elman, the gentleman from those companies were over here, went over to try out their systems, see what they had available. And I said, yes, but can it do this? Can it do that? No, not that. It's for implants only. So luckily, I was able to convince them to give me the opportunity to have the first machine after the beta testing was done. And this is what resulted. So my lecture here contains off-label methods, which are, again, advanced techniques. And the goal is to try and hopefully help you understand that a lot of times patients don't have to be fearful of larger surgeries, because we can now push the envelope and make them more minimally invasive through these methods that I'm about to discuss with you. So these off-label methods for dynamic surgery is the fact that we went back and did a little bit of a retrospective study. Over 18 patients is back in 2018 numbers, 23 rib splits, with the placement of 29 implants. Complications, we lost to a patient to finances, so I don't include her in the rest of the results. 1 graft was lost to a non-vital adjacent tooth. And then 1 implant was lost to a retained root tip, and 1 implant was lost to poor soft tissue in a smoker. So what does that ultimately mean? Basically, we're talking about 3 out of 29, so we're losing somewhere in the neighborhood of about 10%. Which is acceptable considerations with the fact that we're doing these advanced things in a flapless manner, not only for placement of the implants, but also for the grafting techniques. Some of the grafting techniques that I'm going to show you will be from the onset. So some of the incisions and some of the flaps were larger, but I will also show you some of the more subtleties that we've changed to keep the flaps even smaller. So we did this in 7 maxillas, 15 mandibles, Single tooth sites, which ridge splits and osteoperi flaps are not recommended for, have worked well in 9 attempts back in 2018, and then multiple tooth sites in 14 ridges. So you have to remember that early on, a lot of the ground rules were things where you can't do that. Well, why not? And well, your heart's going to explode. Well, you can't touch the brain. Why not? Your brain's going to explode. I mean, we really didn't have basis for all these foundings, so it was always, reach for a leech and try and fix things that way. So in '82, Dr. Barry Marshall started to push the boundaries on this and basically gave himself an ulcer and proved that these ulcers could be founded on the basis of H. pylori as being the cause. And of course, the medical community totally tried to ban him as a lunatic because of the fact that he had tried these methods on himself, but ultimately he gained respect for it because it turned out to be true. So how many people would also think that your bowel movements would affect your brain? And Harvard has also made those connections as well. So what does this mean? It means that we have to wrestle with ourselves and our own cognitive dissonance, in the sense that we like what we tend to feel comfortable with, what we know. So we don't want to let go of that, and it's hard to leave that comfort zone. So the goal is to not be a one-trick pony. And what does that mean? Well, with these advanced techniques, you shouldn't be only diagnosing the implants that you can do. You should be giving the options of a patient to allow them to see the fact that they are able to have these procedures done, and with high success rates, even though you yourselves as a clinician may not be doing the actual surgery. The team approach is still in effect, and it should be something that patients should be educated on and sought after. So this is my trust but verify little story along the lines of the fact that this is my little girl. She's 4 years old. Because of the delays, I'll give you a brief synopsis. She was 4, wanted to take control of her showers, wasn't doing a good job. My wife started a bum check score, and that was the idea, to make sure that she could quantify the fact that she was doing a good job. She didn't understand. So she had seen me use those little facial scrublets here on the wall, and ultimately decided to start using that in her shower, and wasn't just using it on her face. Little to my knowledge. My older daughter came and told me, hey, you may want to check. She's using those in places that you may not like. So what's the purpose of telling the story? That she should get rewarded for problem solving? No, it's about the fact that it's perspective. She thinks everything is clean. I know better, and then I get a good chuckle out of the fact that I'm now wiping that on my face. So I can get upset, I can laugh, but ultimately my perspective is what's going to take on my goals in imparting to you. That we have to trust and verify these guide stents. We have to trust that people are doing a good job. We have to trust that we're trying to be better for our patients. And when it's all said and done, can we say that your CBCT guide or the splint is doing the full job? Likely yes, if it's utilized properly and thoughtfully. The basic fact is mistakes happen. And if they happen in a static situation with a hard splint type guide, wouldn't it be nice to be able to make changes? However, we have money invested, we have time invested, and that may not always be necessary or not always possible. So a case in point, here's my first static guide case. And we basically did this with a company that obviously has a shiny all-on-4 system for navigation and edentulous technique. And they are ultimately known for what you do with an oar. So in that sense, we've got 2 Maryland bridges, and the Maryland bridges were on this patient, 40-year-old teacher that had come to see me, would not get braces, was not happy with the fact that she was losing her Marilyn Bridges all the time. She'd already been through braces. So we decided, okay, this is a good option for a small diameter implant or a mini implant, in her case, even on one side, and we're going to navigate it. So this is the setup. What did we ultimately do? There's seven set up properly in intercortical placement, can be restored properly. Same thing for 10. And then here's where we started. This is our start. Placed the guide. Notice that there was a little something odd here at the guidance disc, and that area looked roughened as if they had buzzed it down. Well, I thought to myself, okay, they had to fit it in between in a tight space. But when you go ahead and look, had I gone ahead and drilled this without justifying starting the procedure and just trusting the guide wholeheartedly, I would have totally put that implant into the distal of number 8. So we're looking at guided surgery then versus now. Primarily, we're looking at what did guided splints allow for patients. They allowed more accuracy. However, they also allow or cost more time, more cost in itself, and also unknown human error. And that's what we exhibited here. What ultimately was found out when I questioned them about this, they couldn't really quite get the right size disc in time, so they basically modeled this one and then hand set that in to position as to what they felt would be adequate. Then what happened is that we've got dynamic navigation. So what we're dealing with now is the future. And this is made possible via GPS type techniques where a camera or stereoscopic cameras will observe tracking barrels on a patient as well as a tracking device on the handpiece. This allows for real-time assessment and correction during the surgery. So if I had that during this case, I could have just made some simple adjustments and continued on as we were intending. But with a static guide, that's it. You have that, and then you have nothing else but your own skills to fall back on. Or you could stop and remake the entire splint. So I'm hoping that with what we're finding being successful, we can predict that this kind of guided surgery could be available for almost every scenario possible that we can think of. So back to their predicament. Had we continued on, we would have probably lost this tooth and also created much headaches for myself in the practice. So what do we have to fall back on? We have to fall back on freehand placement. And we'll see where this is relevant shortly because of the fact that this is a case that I can tell you was all mine. Patient slowly came in, did one section at a time. Before you know it, we had almost done a full mouth rehab on him. And while we can say that no technology is going to make this more accurate, or sorry, more precise, we can say that it will make us more accurate. However, when you have to fall back on your own skills, the technology itself isn't going to make you a better surgeon or clinician. The proper training and knowledge and time and experience is what is required. So what might have happened, again, like I said, if I had blindly followed that splint when we stopped in the middle of the procedure just to get a CT to make sure we were in the right place. So cortically, we were in appropriately, emergence-wise, we were appropriate. And when it was all said and done, comparison of what I was planning and what we had originally planned, that sense that I had to fall back on allowed me to continue through rather than stopping the case altogether. So this is her restored. And then the idea here is that we're seeking the right answer versus the exact answer. And the problem is that in this day and age, much of our employees, much of the residents early on are looking for the right answer. where are we? We are on the Earth, correct. Well, where are we? We're in here, correct. Drawback is we're looking for details, and details are not easy to find sometimes or easily sought after. So we're looking at the fact that if we put in the detail, where are we? We are at the AAOS meeting online, and is being hosted by the Global Symposium. Your address goes here wherever your current location is, and obviously it's Saturday, November 21st in Columbus, Ohio. So what's the difference? We've got each individually correct or right here, but we need all this information to be exact. That's the difference in my eyes between static versus dynamic. So when we go to the next state, we're looking at excellent freehand placement. And the question mark is, it looks good when we first analyze it. We're looking at a good emergence profile, good load axis. However, ultimately, the right answer is what we've achieved. It's a bit of a lag. So we're looking at the implant in place. Restoration should be good aesthetically. It's within the arch. Load is appropriate. However, when we go to find that the third dimension that we were lacking, we find that we have perforated the lingual plate. Now, this case, we didn't really have any complications from other than a little bit of floor of the mouth swelling and some discomfort, but the implant healed fine, was restored fine. However, we were not as exact as what we were trying to find. So when it's all said and done, we can't see when we can't see. And the idea here is either we make flaps like Dr. Resnick was talking about earlier, that you open up the site and not try and do something flapless. But now we have the ability to utilize technology to allow us that vision without making those flaps. So we would be able to take into consideration the angulation of such a mandible and that mylohyoid area defect on the lingual. So there's an old saying that's basically, there's a million ways to skin a cat. And again, we talk about perspective, and it's very quick and easy to see how friends sometimes obviously could become food or otherwise. But the idea here is that we want to seek precision, and that with that, can we find the exactness that we're seeking? So Dennis came to me, friend referring Doc, and said, hey, broke this tooth, the other tooth is having a problem, and I need it out. These were some of the toughest teeth. He also made it more difficult by the fact that he was requesting no sinus lift and no anesthesia. So we had to use a peritome on him and remove all these segments of teeth. And of course, this is a typical root canal set of teeth. And obviously, as it always happens, you never want it to be as hard as when it's a friend as well as a colleague. So the precision that was required was the fact that he requested no sinus lift. And of course, he's a dentist. So we've put all these additional categories and pressures on me to perform and provide the requested things, although it would have been a very easy thing to bump up the sinus. The technology now allows me to be accurate when we're placing an 8.5 millimeter implant and go to 0.1 millimeters and stop short of the actual implant. This picture was taken while we were actively doing the surgery, and we'll go over the different windows and what they mean here shortly. but it allows us to go ahead and remove the teeth and bone graft, put the soft tissues back, and allow for a good result afterwards. So let's talk about the actual system orientation. The windows in the this specific guidance system, this upper left window is the depth and the direction. It allows you to see how deep you're going and whether you're on target to the depth that you want. You're also going to have the angulation. So as you tip left and right, forward and back, this angle meter changes. Now, the X, Y, and Z window will allow us to see how close we're getting in the coronal, sagittal, and axial windows of a CT. And then the further right, the GUI window, which is the graphic user interface, which actually overlaps what we would see in real life. So my real handpiece has now become a computer graphic, and the patient CT has been blended together within the machine to allow you to see real-time turn-by-turn, angle-by-angle motion that you're doing during surgery. So in reality, you're actually looking at the window of the computer screen rather than in the patient's mouth. Now I've trained the assistants to watch, as your assistant should also be able to know what you are doing, and it can't just be there to hold the cheek or retractor or do the suctioning. So the next window is the data window, and the data window, oh, sorry, let me go back. This is, I'm sorry, I lost that arrow there. This is the navigation cameras, and the navigation is the stereoscopic navigation. You can see these lit up areas. This is the barrels that are tracking devices that the camera seeks out with. They have patterns, and that allows the computer to read and draw in where you're actually in position on the CT scan. The next one is the data window that gives you what we are actively placing, sizing of the implant, the measurement from the head of the drill to the drill bit end. So as we start attaining more and more information, wisdom, you're obviously more aware. But at the same time, we're now dealing with the fact that you're aware, but the other people are still dealing with their cognitive dissonance. That makes you the person that's, you know, dancing to the beat of a different drum. And in this case, Albert Einstein, Dr. Einstein here, was a great lateral thinker. And that process of learning how to think laterally ultimately is what made me more excited about what I do, and actually made me better at what I do. So either way, when you have philosophical to scientific observation, you have to think linear and lateral at the same time. And it's not as easy, but it takes a little practice. We've all been through a lot of education. So our education allows us as doctors to learn how to learn. And I think that that is, again, something that is a technique that pretty much everybody needs to apply and learn to utilize in their daily clinical setting. So back to our million ways to skin a cat. If there's a million ways, in my eyes, you can't, again, be the one-trick pony. So we have to have at least and be an expert of 3 of those techniques to be an expert. So I have your favorite method. Hey, it makes things more fun. You're better at it. You're quicker at it, whatever it is. And then you have your fail-safe method, which technique that you know how to do, you know it's going to work. And then obviously you have to have your bailout. You don't want to be experimenting during a procedure when it doesn't go the way that you expected. And like Dr. Resnick was pointing out to everyone, you have to be prepared for these situations. If you don't have the equipment and something happens, then you're, again, not ready. So be a Boy Scout. Girl Scout, person Scout. So which is the correct method? Your favorite method, your fail-safe, or your bailout? Well, they're all correct. Thing is, again, it matters whether or not it works in your hands, and depends on which one you use and can use safely. So with the system here, I'm just going to let this run for a few moments. What this is showing you is I'm going at a slower speed than I normally do and drilling to the depth, but you can see how it's literally reading to the 10th of a degree as to how much my hand is moving. I'm slowly progressing along. And when you see the depth coming down, we're following right to the guidance of the position that we have treatment planned on the software. And when we go to check, obviously we blocked the camera, so it will show that your guidance system is not working, and it will block that for you so that you do not continue. As soon as my head gets out of the way, or an assistant's hand gets away from the tracker device, then the system restarts itself. So in the world of dynamic guided implants, what are we talking about as far as GPS surgery? Current method, static guides, mostly laboratory fabricated. Again, we talk about the fact that they cost a lot of time, both to plan as well as to make the guides, shipping, etc. Effort to place the guide before its use. In other words, sending it off, talking with a lab, doing the computer meeting to make sure that everything is the way that you wanted. In that first case, I was called up. We did the meeting and said, "Hey, it looks great, Dr. Bath. I think it'll be a great. You okay with me just saying okay to it?" And I said, "Absolutely not. Ultimately, it's my responsibility. So we're going to kind of go ahead and tweak things." And of course, we actually had probably about a 15-20-minute meeting over those two initial implants that we showed. So additionally, there's an additional cost and expense for both the doctor and the patient. And with GPS surgery, there's no guide. The time to plan is still there, both for the implants as well as the surgical cuts. But it's no different than what we do in my training for osteotomies, orthodontic surgery. You had to actually do the surgery on a set of models. It's no different than what you would do to do a wax up for a full rehab case. When it's all said and done, in my eyes, there's less effort, there's less surgery, and there's no guide. However, there is the cost of the actual machine, which again is an investment in your equipment. And then there's less to no lab cost. So when it's all said and done, both allow for improved accuracy. And as we've demonstrated earlier, we've discussed, you can't adjust your plan once the surgery's begun with a static surgical guide. But with what I'm going to show you later, there's going to be another situation where I've done exactly that. So let's finish up talking about what is this accuracy that we're talking about. Let's talk about the science and the fact that these people have studied this, at least 3 different studies here that we've got listed, and the fact that ultimately we're touting a 0.25 millimeter linear accuracy and a less than 2 degree angular accuracy with the hand guided by the dynamic navigation. With a static guide, you are more accurate than freehand placement. It's considerably more accurate, about 8%. And then when you're looking at the positional accuracy by freehand, you know, there are those other aspects like we've seen already in the 3rd dimensions of what we can't see that can come into play. So if GPS technology can help us plan, what if it could also help us cut? If it's guiding our hand in how we're making the osteotomy of an implant, why can't it guide us on a planar region, which is what I started to opposed to the company on that initial day that I met them. So we're back to the cognitive dissonance. I actually had to convince them that what I was trying to do was going to be safe and okay. It took some convincing, but they said, hey, it's up to you. We trust you, go for it. So, of course, all responsibility falls on me to do these off-label things. It's hard to leave that comfort zone. To me, sometimes, though, it's kind of fun to be inventive. I'm not utilizing this comfort zone to just be a cowboy and do whatever I want. I'm applying the linear education that I've been given and applying it laterally to other aspects of clinical acceptance. Hitting the ideal mark, we want to basically give the patients the best of the best. We must save the teeth until it's time not to save teeth. That is most dentists' motto. However, when we follow this protocol, we should also think about preserving bone. We shouldn't just say, hey, we should be doing a root canal on this tooth so that we can say salvage it. We could get extra time out of it. But at the same time now, we've easily, because of a monetary aspect, switched that thought process to now we must extract teeth and reduce bone. And why is that? Well, we need the physician to be able to put the prosthetic device on top of the implants. Okay. Well, it looks like we're going to be short on time. So we're talking about foundations. The foundations are basically the fact that this one looks more like a bone graft. This looks more like a ridge split. So when we're looking at the fact we have to consider bone grafting, what we used to do prior to regenerate bone where it was lost, ridge splitting. In my eyes, ridge splitting has become ideal. GTR, excellent. I've gone away from my original favorite way of doing things, which was the block bone graft. So when we have truly flapless implant placement with the guidance, now you know where you're placing it, you'll be happy, much unlike what some of the cases that Dr. Wienhaven showed us this morning. Some GTR cases, soft tissue control, different things that you can do. Transitions, basically going from a sliding ramus and genial block graft to being my favorite to now using and utilizing ridge splitting osteotomies. Let me get you to a point where we can see what happens when you don't have that third dimension. We had a ridge split that buccally and anteriorly went the way we were expecting. Lingually, however, it went awry and went to what we would call a bad ridge split or a bad fracture. The anterior portion went correct, unfortunately, because as it is thinner, the more forward we go, the more posterior we go, the mandible, the lingual plates become more thin, and we're fighting against that buccal plate and the ramus and that thickness. So it's much easier to not have your osteotomy complete. You can see the swelling, we closed it up, achieved what we wanted to, but we lost perspective. Changes how you feel about something, changes your confidence in the outcomes, and that case in itself almost made me want to stop doing ridge splits altogether. I did not do that with the navigation system, but I do now think it's ideal. So this brings me to my work now with the osteoperi flaps. I've furthered this work by now ultimately taking the buccal plate and controlling this by making cuts that I can see in minimally invasive flaps. So this is the first case that I did. You can see the defect. what we were losing, and ultimately what we were able to do. And that was all through small little flaps. So initially I made a larger flap than I normally do. That is the periosteum, so we can see it. The goal here is to prevent large flaps in this area here. This allows me to do the horizontal cuts beneath. Through osteotomes, we've split that alveolus, grafted, and the nice part is through manipulation, we can fixate that graft out and up and get a primary closure. So when you take a look at this small incisions as opposed to what we would see initially when we would go to something like this. Large incisions, this is a method that I have that I've kind of utilized to suture and hold in the membranes, utilizing the actual periosteum, but it also allows me to control the tissue of which you have to release so that you can move it vertically and buccally over top of the gained space. Primary closure, this is with nothing being held in position, and it is staying in place with no sutures. So comparatively, when we look at this for a GBR type case, see the membrane above, we've used allograft cortical cancellous mix, and then we've used PRF to hold the bone together. And then of course the sutures kind of maintain and hold everything else in place. Comparatively, this is way more palatable. So this is Randy. This is some of the advanced stuff that we've gotten into. We've actually started to take a ridge split, use the system, patient tracker, measuring plate, drill tracker. This is the tracker inside the patient's mouth. The osteotomy is about to be cut through this small incision. There's the bone underneath. Well, now we start drilling. Well, what's the purpose of the drilling? The drilling is to now have what I call these surgical pins. So that gives me all the angulations that are present in the surgical environment that I need to see. The implants themselves are seen here and here. Then we notice that this implant properly loaded, properly positioned, and properly sized to withstand the forces would not have adequate bone here. So what we've done is combined the split with placement at the same time, and you can see all the various angles that come into play when we are trying to achieve this in a flapless area. So it's no wonder when we can see some of this, but we lose sight of what we're trying to achieve because there's so many planes that we can't address, and now we can. So this is now all the pins in place. We use the osteotome here to go ahead and measure into a 10-millimeter depth, and then follow the pins, removing them as we go, as we make the cuts with piezotome, and ultimately are capable of separating the osteotomy. If they're not complete, then we can go back and cut some more osteotomy again with the osteotomes, and ultimately we have a split. Once that's done, you can use that little vertical incision that I made to use the horizontal cut to mobilize the osteoperiosteo flap, and then start drilling for the implants. The implants were then placed. You see that they're going to be loaded appropriately. Buccal plate is now out to the buccal appropriately to allow adequate width of a large diameter implant, both placed. Then we go to PRP and bone grafting and pack around the implants. Once that's all said and done, we can now manipulate that buccal flap with the bone and soft tissue intact and actually pin it in place right through that same incision. And then we get primary closure. So this was the after panoramic view. And now we've taken a 4mm mandible, made it at 10 millimeters. This patient is now restored, and it's ultimately a challenging but fun way to use this technology. So this is our perspective again, and we can continue to go on, but I will just say thank you. I hope that you've enjoyed what we've done with these. We've done distraction, allowing us to also control vectors because of the actual surgical cuts. I've developed all these different types of methods to utilize. Other people are now utilizing these procedures and have been. The biggest one I think right now has been very interesting is the endodontics. One of the things that they came up with was little tiny ninja-like access opening. So there's no traditional large central access opening during endodontics. They're actually coming in at different angles and now only having to utilize small access openings, which don't require a full crown to cover it, provided that the tooth does not require it. I think that the ceiling is unlimited, and it's really an exciting time. I hope that we can do this all again sometime, and I can show you some of the other cases that we've had an opportunity to do and utilize this method of combining both CBCT and three-dimensional guided surgery to make our patients believe that we're better, and we need to believe that we are heading in that direction to do everything what's in the patient's best interest. So I appreciate your time and appreciate your attention. I hope you enjoy the rest of this weekend at the AAOS meeting, and thank you for listening. Thank you for everyone that was here to listen, and I appreciate the opportunity. Thank you.
Thank you. Hello, everyone. Thank you all for attending this conference. My name is Pooja Gangwani, and I will be presenting on management of medical emergencies. So we're going to touch upon the background of medical emergencies, how to prevent them, discuss emergency equipment and emergency medications that should be stocked in an outpatient setting. And then we'll run through cases to make it interesting on recognition and management of the medical emergency. Let's start with introduction. Medical emergencies are an unavoidable part of our profession. With our patients' life expectancy being increased with advances in medicine, multiple comorbidities being handled by multiple medications patients are on, we are bound to experience a medical emergency in our offices, and therefore we must be prepared. Malamud reported that 96.6% of respondents of a survey among practicing dentists had a medical emergency occur in their office. And it can happen to anyone, a patient, doctor, office personnel, or a person accompanying a patient. And so it's crucial that we're aware to recognize them in timely fashion and manage them appropriately. Majority of the medical emergencies occur during or immediately after administering local anesthesia. Procedures most commonly associated with medical emergencies are extraction, pulp extirpation, kind of invasive procedures that make people anxious. And about 75% of times they're related to stress. So management of stress becomes really important. And prevention is key. That's the best way to handle a medical emergency. That is to recognize and prevent it from happening. And how do you do that? Obtaining thorough medical history comes first, not only at their first visit, but updating medical history, the list of medications that they're on, and allergies at every visit. It is important to determine the medical risk. In other words, ask yourself questions when you see patients that can this patient tolerate a planned procedure physically and psychologically? And obviously, medical consultation plays a great role in optimizing patients' care. But remember, medical consultation is merely a request for additional information to help in the determination of the risk and possible modifications that might be needed. The final responsibility of patients' safety still rests on treating providers. Early recognition is a key and can be life-saving. And teamwork makes the dream work. Definitely not something that you will be able to manage on your own. You will need your staff members to be on board and handling the medical emergency successfully. Patient selection is an important thing to remember. Determination of medical risk plays a role in patient selection. If patients are not optimized for the procedure, defer care. Understand who you can treat in an outpatient setting versus referring to the hospital. Preparedness is an important thing. Fortunately, life-threatening situations are rare and they occur infrequently, and therefore team members can become rusty. And that's when periodic mock codes with staff members come in handy. It is important that staff members are assigned responsibility, that the crash cart is checked regularly. You do not want to have expired medications and empty oxygen cylinder in the crash cart, and when time comes to use, that there is nothing to use on your patients. Always be cautious, never ignore your patient, pay attention to their signs and symptoms, maintain verbal contact, and recognize and manage in timely fashion. Like I'd mentioned before, teamwork makes the dream work. Member one, for example, or who recognizes the medical emergency or is closest to the patient, particularly the doctor or the person who's recognizing signs and symptoms, should stay with the patient. Ask for help and start basic life support measures. In other words, check for pulse and check for breathing. Member number two, get emergency equipment and medications. And member number three, activate emergency medical services, monitor vital signs, and help in record keeping and preparing and administering drugs. Next, we're just going to run through emergency equipments and emergency drugs to be stocked in a dental office, starting with the most important medication, oxygen, a full oxygen cylinder, nasal cannula, bag valve mask, non-rebreather mask with reservoir. Oropharyngeal airway and nasopharyngeal airways are important, especially helping assist in maintenance of patient patent airway in an unconscious person. Yankawa suction comes in handy when you're dealing with secretions and you want to suction and have a clear vision in the back of the mouth. McGill's forceps helps retrieve objects such as broken fragments of teeth, crowns, when they lie in the posterior region of patient's oral cavity. An example of how a nasal cannula is placed, a use of non-rebreather mask, 1 provider bag valve mask, 2 provider bag valve mask technique. An example of how an oropharyngeal airway is inserted, and so is the nasopharyngeal airway. And these are important, you know, when you're dealing with making sure that the patient's airway is patent and the tongue doesn't fall in the back of the mouth to kind of close the airway. Most important and must-have life-saving equipment in a dental office is the AED, because successful resuscitation of a sudden cardiac arrest depends on early CPR and defibrillation. And a glucometer comes in handy, especially when you're dealing with patients who have a history of diabetes and are on insulin. Emergency drugs. Epinephrine used in anaphylaxis, severe asthma attack, albuterol used for an asthma attack, diphenhydramine / Benadryl used to treat non-life-threatening allergic reactions, and aspirin, a part of MONA, now called as ONAN protocol, when a myocardial infarction is suspected. And ONAN stands for O as in oxygen, N as in nitroglycerin, A as in aspirin, and M as in morphine. Nitroglycerin is a coronary vasodilator used to provide relief from angina, can be administered as a sublingual tablet or spray. Ammonia inhalants are used in patients with syncope, glucose used to treat hypoglycemia, and Narcan used to treat opioid reversal. Most important and basic principles to manage in a medical emergency is first, try to stay calm so you can clear your head and understand and proceed. Terminate the procedure, position the patient, airway, breathing, circulation, make sure that the patient has pulse and is breathing, activate emergency medical services, and definitive treatment, meaning administration of drugs based on the medical emergency you're dealing with, or a defibrillator in case of cardiac arrest. All right, let's run through 10 cases and save some lives. Case 1. A 48-year-old female presents for extraction of non-restorable symptomatic tooth number 15. Upon asking medical history, she reports she has history of diabetes, anxiety, hypothyroidism, and GERD. She takes medications for the same. She's on metformin, lisinopril, lorazepam, levothyroxine, and pantoprazole. She reports that her finger stick at home a day prior was 110, and her HbA1c has remained at 6.3. She's nervous and anxious about the procedure. You calm her down and you administer local anesthesia. You give her 1 corpule of 2% lidocaine with 1:100,000 epinephrine. And you see that she's starting to get anxious and dizzy and appears weak, confused, drowsy, and is sweaty. Differential diagnosis of this medical emergency. Syncope and hypoglycemia. Given syncope is the most common medical emergency, should come to your mind first, and hypoglycemia given her medical history that she's diabetic and is on insulin. First things first, let's make sure that we follow ABC protocol, airway, breathing, circulation. Make sure she's maintained verbal contact and that she has pulse and she's breathing. Make sure she's comfortable, so lay her in supine position, elevate legs so that it can improve blood supply to the brain, and assess vital signs and administer oxygen. Upon assessing vital signs, they are sort of within normal limit, except for she's now tachycardic and her heart rate is in the range of 105s. Next, you want to check her blood glucose level so that you can figure out if this patient is hypoglycemic or is experiencing syncope. So if the glucometer reading is 105, she's not hypoglycemic, she's experiencing near syncope. And so the treatment would be respiratory stimulant. Respiratory stimulant in the form of aromatic ammonia, the noxious odor can irritate the mucous membrane of upper respiratory tract and stimulate respiratory centers of medulla, awakening the patient. And if the glucometer reading is 50, hypoglycemia, treat with either glucose tablets or orange juice if the patient can handle secretions or can maintain airway, or can start an IV and administer 50% dextrose 25 grams or intramuscular glucagon 1 milligrams. Allow the patient to recover, monitor the patient, and discharge if stable, and if the recovery is not immediate, and transfer the patient to the hospital. Let's quickly review vasovagal syncope. Most common emergency characterized by abrupt and transient loss of consciousness, inadequate cerebral perfusion, inability to maintain postural tone, and results in the drop of systemic blood pressure. This is usually rapid and the recovery is spontaneous. Signs and symptoms that patients can present with: lightheadedness, dizziness, fainting, pale appearing, sweating, visual blurring, reduced hearing, nausea, vomiting, low blood pressure, and low heart rate. Pathophysiology of vasovagal syncope is that it is reflex mediated by autonomic nerves, leading to vasodilation, thereby causing hypotension, bradycardia, decreased cerebral perfusion, and fainting. Triggers are emotional stress and anxiety and pain, orthostatic hypotension, and hypoxia, meaning low oxygen in the blood. Management starts with basics: airway, breathing, circulation, supine position, elevate legs, administer supplemental oxygen, loosen tight clothing, assess for vital signs, and respiratory stimulant, aromatic ammonia, to awaken the patient. Let's quickly also review hypoglycemia. Symptoms of hypoglycemia can develop really quickly and progress into unconsciousness and results in sudden emergency situation if not recognized in timely fashion. And glucose levels below 54 is clinically important, and clinically important hypoglycemia is important to prevent from escalating further. Always inquire about their last insulin dose and when they have eaten their last meal. If a patient has failed to eat, administer source of glucose prior to starting a dental procedure. Signs and symptoms of hypoglycemia include tremor, palpitations, anxiety, sweating, dizziness, weakness, drowsiness, delirium. If untreated, will lead to confusion, seizure, and coma. Basics first with management: airway, breathing, circulation, check for blood glucose, and administer oral carbohydrates if patients are awake and able to tolerate their secretions and maintain airway, or IV dextrose or IM glucagon. Let's go back to case 1 real quick and picture if the finger stick was to be 390 with HbA1c 12.6. Now you should be worried about severe hyperglycemia. Typically, such patients will present with signs and symptoms of tachycardia, tachypnea, abdominal pain, nausea, vomiting, and ketone breath. And these patients belong to the hospital because they require management with insulin drip, IV fluids, correction of electrolytes, and frequent blood glucose assays. All right, moving on to case 2. An 18-year-old boy presents for a restorative procedure, reports he has upper respiratory tract infection about a week ago and now resolved. Past medical history includes asthma, heart murmur, anxiety. Medications include Flovent, albuterol for wheezing, and shortness of breath. Local anesthesia administered, you're getting ready to start the procedure, and you see this. And on further inquiring, patient reports that he has shortness of breath. Based on patient's medical history and based on shortness of breath, the first thing that should come to your mind is asthma, but do not exclude hyperventilation from your differential diagnosis. Although asthma more likely, hyperventilation should be considered. Start with terminate the procedure, place the patient in upright position, clear patient's oral cavity, Basic life support measures, check for pulse, check for breathing, assess vital signs, and you notice this patient is tachypneic, tachycardic, and has low oxygen SpO2. But you need a little more information to decide which algorithm to use. And if the patient reports wheezing and chest tightness, you follow the algorithm to treat asthma. If no wheezing, just reports palpitation, follow the algorithm to hyperventilation. Let's manage asthma first, and then we'll move on to managing hyperventilation next. Administer oxygen, albuterol, and if the attack clears, proceed with dental procedure, or you can discharge the patient if stable and reschedule the treatment. In severe cases, administer epinephrine at the dose of 0.3 to 0.5 milligram, either IM or sub-Q, and call emergency medical services because severe cases either require nebulizer treatment and rarely intubation. So therefore, they belong to the hospital. Let's go back to case 2 and treat hyperventilation. If the patient did not have wheezing, but just had shortness of breath and palpitations because the patient was anxious to be in the chair with additional signs and symptoms of dizziness, confusion, and lightheadedness, have the patient breathe in a paper bag. Oxygen is not the treatment for hyperventilation. Continue if the patient is stable, discharge with an escort. Let's quickly review asthma and then hyperventilation before we move on to case 3. Asthma is characterized by symptoms of chest tightness, dyspnea, wheezing, anxiety, confusion, nasal flaring. They are tachycardic, tachypneic with high blood pressure. Early recognition and intervention can be life-saving. Pathophysiology of this disease is characterized by narrowing of airway lumen, reduction in blood flow, caused by contraction of airway smooth muscle, thickening of the airway wall, and plugging of the airway with mucus and debris, thereby reducing the diameter as shown here, leading to wheezing and shortness of breath. Triggers for asthma attack are allergens, upper respiratory tract infection, emotional factors, strenuous activity, and lack of adherence to medications. And its administration starts with basic life support, administration of oxygen, albuterol, in severe cases, epinephrine. Hyperventilation, on the other hand, occurs due to anxiety. It's major predisposing factor, causes increased in rate and depth of respiration, leading to decreased carbon dioxide in blood, leading to respiratory alkalosis and following symptoms. Ultimately, patients will complain of tachycardia, shortness of breath, lightheadedness, and confusion and tingling of hands and feet if untreated. And management of hyperventilation, when they kind of wash out their CO2 and their oxygen levels increase, no oxygen, and treat with having them breathe in a small paper bag. Let's move on to case 3. 45-year-old female presents for an extraction of asymptomatic non-restorable tooth number 31. She reports her medical history positive for aortic valve replacement, hypertension, diabetes, hyperlipidemia, and is on medications for the same. She reports allergies to lisinopril. Her vitals and lab work is under normal limits. Given history of aortic valve replacement, you pre-medicate the patient with amoxicillin 2 grams orally. Local anesthesia administered and the procedure is completed. After the extraction procedure is over, you notice slight swelling of her lower lip and rash on her chin and neck. Differential diagnosis, given signs and symptoms, allergic reaction. You turn around and look at her, that's concerning. Check for airway compromise, swelling of tongue and oropharynx, and activate emergency medical services. Check for pulse, check for breathing. Airway management becomes really essential. Intubation if respiratory distress, and IM administration of epinephrine. Allergic reactions and anaphylaxis can be fatal, and therefore early recognition and treatment is life-saving. It can cause respiratory and cardiac arrest within minutes, especially if the patients have anaphylaxis, angioedema, their lips and tongue and oropharynx are swollen, and they have dyspnea and hoarseness with low blood pressure. they really go down south soon. Airway management becomes key. Intubation of respiratory distress. IM epinephrine is the treatment of choice. Adjunctive treatment for managing allergic reactions, diphenhydramine, H1 blocker, bronchodilators for opening up their airways, such as albuterol. Methylprednisolone will help bring the swelling and edema down, and famotidine has been a part of the protocol. It's an H2 blocker that helps with reduction in urticaria and rash. Mild allergic reaction usually responds to administration of Benadryl 50 milligrams every 6 to 8 hours for 2 days. Let's just quickly review epinephrine. It's a life-saving drug, and it's really important for us to know what it does. Responsible for increase in vasoconstriction and peripheral resistance, thereby bringing up the blood pressure, reducing mucosal edema. Also is responsible for increasing ionotropy and chronotropy, meaning improves myocardial contractility and heart rate, causes bronchodilation, and reduces the release of inflammatory mediators. And therefore, it is a drug of choice and a life-saving drug in medical emergencies that include cardiac arrest, severe asthma attack, and anaphylactic reaction. Moving on to case number 4. Okay, you're performing an extraction procedure. You elevate the tooth and a heavily restored crown fractures. With the noise, patient kind of gets nervous and moves. And even though the gauze and throat screen was in place, the fractured crown finds its way to the pharynx. You're now thinking either this patient has aspirated the fractured crown or has ingested. Well, if the patient is calm and is not coughing and talking to you and is not choking or has no difficulty breathing and has a normal voice, the chances are that this patient has ingested. Whereas if the patient is coughing and choking and wheezing and is experiencing labored breathing and hoarseness, most likely the patient has aspirated this object. And so you would have to start with basic life support, supplemental oxygen, airway management, and Heimlich maneuver. Heimlich maneuver is performed by standing behind them, wrap your arms around them, make a fist, put it over their belly button, and apply abdominal thrust, pull it in and up so that the objects get dislodged. If the patient is unconscious, you won't be able to have them stand, lay them down, roll them over, and apply abdominal thrust. Imaging plays an important role in respect to localizing where this fractured fragment of tooth is, and then handling it appropriately. If in lungs, will require bronchoscopy. If in GI, will require close follow-up, close monitoring with confirming that the object has passed with further imaging. And in symptomatic patients, or if the object has not passed and it's been 7 days since the ingestion, refer to GI specialists for an endoscopic removal. Case 5. 32-year-old male presents for restorative work, reports has a history of traumatic brain injury, seizure, and depression, is on medications for the same. Halfway through the procedure, patient reports feeling dizzy, appears confused. You terminate the procedure immediately. Now a patient starts to experience convulsions and excessive salivary flow. Based on the medical history and based on what you see, like convulsions and excess salivary flow, you are thinking seizure, and that's what the patient does when the patient is seizing. So what would you want to do? You want to place the patient in supine position, have them turn on one side if possible to avoid aspiration, clear all the equipment from the area so that they don't end up hurting you or themselves, clear patient's oral cavity, and basic life support, airway, breathing, circulation, assess vitals, administer oxygen, time seizure, and administer diazepam. Examine for traumatic injuries, because most of the times patients who are seizing can end up biting their tongue, leading to tongue and lip lacerations. Now, if the seizure breaks, allow the patient to recover and rest, monitor their vital signs, and if they return to baseline and their signs and symptoms have resolved, and they're awake, alert, oriented to place time in person, they can be discharged with a responsible adult with a follow-up with their physician. However, if 5 minutes have passed and the seizure activity continues with more than one seizure without recovery in between, patient is suffering from status epilepticus and they need to be transferred to the hospital right away. Seizures present as clinical manifestations of abnormal excessive neuronal discharges, primarily in the cerebral cortex. Usually self-limiting, last for a few seconds to a few minutes, and EEG is used for diagnosis, characterized by sudden collapse, loss of consciousness, tongue biting, rhythmic jerking movements, incontinence, and cyanosis. And triggering factors for seizures are emotional stress, physical stress, fatigue, and flickering lights. Management of status epilepticus includes discontinuation of dental treatment, making sure that they're in supine position, clear all the instruments, clear the oral cavity so they don't end up hurting themselves, ABC, oxygen, diazepam, and rapid finger stick to rule out and treat hypoglycemia. Case 6, your office manager comes running in the back and grabs your attention, and she mentions that the patient that just checked in felt dizzy, diaphoretic, weak, and collapsed. Uh-oh. Calm down, check for pulse, check for breathing, look for loss of consciousness. If no pulse, no breathing, no loss, and loss of consciousness, begin CPR and activate EMS. However, if the patient is awake, able to communicate, inquire about signs and symptoms, and ask for chest tightness. If the patient appears to be diaphoretic, activate EMS and administer nitroglycerine after you assess for vitals and oxygen. Angina, chest pain attributable to myocardial ischemia. Timely diagnosis and treatment is necessary, and anginal pain can present as squeezing, tightness, pressure, fullness in the chest radiating to the lower jaw on the left side, and is associated with symptoms of shortness of breath, nausea, diaphoresis, fatigue, dizziness, and lightheadedness. Classic angina is often relieved with termination of provoking factor or use of nitroglycerin and will last for 2 to 5 minutes. However, myocardial infarction requires presence of myocardial injury detected by abnormal cardiac biomarkers in the setting of acute myocardial ischemia. And there are 2 types, STEMI and NSTEMI, that require a diagnosis based on EKG and elevated troponin. Management of patients with cardiac arrest, angina, or myocardial infarction starts with basic airway, breathing, circulation, check for pulse and breathing, activate EMS, administer oxygen, nitroglycerin, aspirin, and morphine, the ONAM protocol. Patients at the hospital go through extensive lab work, EKG, chest x-ray, cardiac enzymes, possibly cardiac catheterization and revascularization procedure. Case 7. 72-year-old male presents for consultation for his fractured and symptomatic tooth. Reports has a history of hypertension, coronary artery disease, hyperlipidemia,